Don't. Okay. All of you are welcome to the online session on chest X-rays, and most of the X-ray findings, normal findings, will be available in a very good book of Felsen, and I would be able to share with you the WhatsApp to this number. Let me start the session by taking you through that the children are different from adults. The X-ray, a normal X-ray of a baby, a newborn, is different from that of a child, which is X-ray number 2, and to that of an adult, which is X-ray number 3. What is the difference that I am seeing? First of all, it is not the size of the X-ray. X-ray size will be same. The only question is the look at the configuration of the thorax. It's conical to little less conical to cylindrical. And the next part is that means to say as and when. What do you mean by emphysematous chest? Well expanded chest, correct? It will be like an adult chest. If you make it over adult chest, I'm sorry for using that term, it becomes an emphysematous chest. That means the more and more air you can hold and breathe, you will become more and more adult type. That means, first of all, a chest of a child is compromised. What does that mean radiologically to me? Radiologically, it means to me that, you know, the radiologically, it means to me that there is restriction of the spaces and there is a lot of overlap of structures, and the thymus occupies nearly a large part of the chest. Now, you look at the X-ray number 2, also X-ray number 3. Look at the position of the ribs, the configuration of thorax, the way the hemidiaphragms are there, everything. So basically, I want you to just be familiar with the normal age related normal X-rays so that you will not make any mistakes when you are interpreting. Look at I will take the example of a thymus. Thymus is basically an intrauterine lymphoid organ which also is present in extrauterine life, and over a period of time it is going to get involuted because the role of thymus becomes less and less, and there is shrinkage in the size of the thymus, and the thymus almost disappears on radiologically, I mean to say almost nil, by around puberty. Now this thymus is a radiolucent bar radio opaque structure that you see and can mimic many intrathoracic lesions of the chest X-ray. And sometimes we are confused whether it is thymus or not. And thymus also overlaps with many of the structures, and therefore you need to know about thymus. The most important thing is I will tell you in subsequent slides about thymus. But at this stage, what you need to know is there is thymus age appropriate. That means you have at young age more of thymus, less of thymus as the age advances. Remember, the second thing about children is that the cardiothoracic ratio is more than that of an adult. Younger they are, nearly 65-70% in newborn and shrinking to 60, 50, so on and so forth. And in an adult, you have a different cardiothoracic ratio. That means for those of you who wants to make a diagnosis of cardiomegaly, there should not be oligothorax. The problem of cardiomegaly is wrong. It is not physiological cardiomegaly. It is oligothorax that is present in a newborn that makes it relative cardiomegaly. I don't know whether you understood. Please type U if you have understood. What I meant was that, you know, it is that the chest is small, not that the cardia is large. So for the given chest, the cardiothoracic ratio appears as though it is normal. That's why I put you the first X-ray of the newborn for you to understand that the cardia is occupying most of the thorax while thorax is small in a newborn, and this continues with the age in a progressive manner with growth and expansion of the chest in such a way that their cardia appears small for the given chest. The next is that you look at the ribs. It is most Dr. Ravikiran is asking repeat. Okay, I'll repeat for Ravikiran. See, please understand that in a newborn, chest is small and the heart occupies, let's say, 3/4 of the chest. It does not mean that there is cardiomegaly. It means that the chest is small. Therefore, the cardiothoracic ratio is high. But when in an adult, the chest is grown and therefore cardia forms less than 50% of the thorax. And therefore, the cardiothoracic is small than compared to newborn. Dr. Vikiran, is it okay? Any of you can interrupt me. Fine. Now, for further, any of you can ask me to repeat, I'll repeat, no issue. In the ribs are horizontal in a newborn and they become oblique as the age advances. I'm just showing you these two arrows. You can see they're horizontal in newborn. They become oblique as the age pass by. And why this knowledge is important is because I'll give you a small example. Can you see the confluence between the two ribs? I'll just follow my cursor. This is the posterior end of the rib, one, and this is the anterior end of another rib. These two bisect like this, and at the level of bisection, any shadow will appear more radio opaque. Exactly, I put my cursor. I don't know, can you see my cursor? Can you see my cursor here? I'll repeat it for you if you want. That means to say, here what happens is, whenever the ribs or any of the structures overlap, it is not necessarily rib. I'll just give another example of overlap of a clavicle here with that of a rib, or that of the cardia with the rib with the lung. Can you see here? Here the ribs appear less osteoporotic. I would use the word. Less osteoporotic means the ribs appear more dense around the cardia, but they are not dense. This is an apparent feeling. Why this is important is because whenever you have pneumonia patch on them in these areas or nodules in these areas, they apparent or falsely appear more radio dense. I recollect many of the pediatricians will show small shadow. Sir, here some patch is there. Remember, please look at this factor. Is it because of crossing, overlapping, false amplification of the radio opacity? This is very, very important for all of us. Therefore, in infants, we are very, very lucky because most often the ribs are horizontal and they don't cause this much of problems. But whenever you are looking at adolescents and adults, this becomes an important factor. Diaphragms are in higher position than normal. This is important. Again, you look at an infant's X-ray or a newborn X-ray, see you say abdominothoracic breathing, they have larger abdomen, a smaller chest, and therefore the diaphragms go up. Now, why this point is important is because you tend to make some diagnosis, which I don't want to tell you now, just because of overposition of the diaphragm in the thorax. Be careful. I'm not telling that this will become a factor of a problem for you in diagnosis, but this is a point to be noted. It's a very minor point, but needs to be noted. Now, pulmonary vessels are also important because if you don't know the normal anatomy of pulmonary vessels, there is either overdiagnosis or underdiagnosis of pneumonias and bronchovascular markings. What I meant by pulmonary vessels, look at the pulmonary vessels in a 16-day-old baby, 7 weeks old baby, and after 3 months. Did you understand? So why this is important is because many a times especially when you are making diagnosis of viral lower respiratory tract infection X-rays, and when you are interpreting, let me also take this point again for discussion and I will update you. Right now here, understand that normally the pulmonary vessels are seen and they can be traced up to nearly 2/3 of the lung fields. The last 1/3 you don't see. It is not that they disappear in the last 1/3. They become thinner and thinner, sufficient enough that the blood within the vessels is not seen on an X-ray. The next point that I wanted to tell you is that, please remember that in a newborn, this is how you will see interstitial markings in a TTN or a wet lung versus a normal newborn. So my point here is not about showing you the findings. My point is, please ask for the age of the child, because without knowing the age of the child, you should never ever try to interpret a X-ray. Now let me come to the next point, that is the position in which the X-rays are taken and how does that influence our interpretation. If you take in supine, diaphragms go up, the position of the ribs are different. And when I say supine, even for example, a portable is a supine film or a semi-reclined position. And lot of variations happen. Diaphragms go up, then the cardia, we start commenting on cardiomegaly, and ribs become more oblique. You understand, lots of issues are there related to supine versus standing. And it is difficult to make a radiological diagnosis to the perfection. The last X-ray here shows a pleural effusion. Because it was taken in supine position, there is no description that you would otherwise read from a textbook. And this can mislead you in an ICU. Did you get my point? No, I'm trying to tell you, please note this about pleural effusion. Dr. Swati, I'm going to repeat completely about interstitial markings later in my session. There is 5 minutes on interstitial markings only, don't worry. And for PA, AP, everything I'll tell you. This is supine versus standing. This is just to know for you, just be aware that position is important. Now I'll come to PA versus AP. Please understand, one hint I can give you, this is not from the textbooks, but from our experience. Any child below 5 years of age, generally, you will go for AP because the child won't cooperate, and or often it is difficult to take a perfect PA film. You understand? It could be sitting, it could be holding, quite difficult to get a PA done in a child less than 5 years of age. So moment you know the age, you will know whether it is AP or PA. That is one part. However, a good radiologist can take a PA film in any age. That's not a point, but I'm just trying to tell you that this is a practical point, not to rule out by age. That's one. Now, what happens in a PA? In a PA, the X-ray source, can you see the image here? The X-ray source is 6 feet or 8 feet away, and X-rays are not are parallel. So when you have a source of the X-ray away from you, it is parallel. You remember the bullet injuries in forensic. If you shoot from long range versus if you shoot from close range, you can remember that effect of smoke that happens at the entry wound. That is because an AP you will take to the ICU or in the area where you want to take the X-ray, and take the X-ray source close to the chest and shoot. You understand? So that means the X-rays from an AP are divergent and an X-ray from PA are parallel. Is that okay for you to understand? Please type okay. I just wanted to know. This is the first step. Okay, done. The next point that I wanted to tell you is that whenever you have this is first principle. That means a size of the cardia, which is shown in the PA, is perfect because X-rays are parallel. Whereas the size of the heart, which is shown in the AP, is magnified. See, this is a portable film, and from here I'm taking the cardia. This is 16 centimeters. Whereas this X-ray source is far, and it is just divergent X-rays, non-divergent X-rays, parallel X-rays, and therefore it gives 13 centimeters. So heart size becomes larger in a AP film because X-rays are divergent. Second is side effects are more. In a portable film, large amount of scattering of the X-rays happen. This is just like a, a, a laser versus a light, an ordinary bulb. You understand? An ordinary bulb will have divergent light rays, whereas a laser will have parallel and a focused rays. Did you get the point, Dr. Vasan Kumar? You have been asking this doubt. So therefore, it means that whenever you take a PA film, you will see every structure in perfect anatomical size and position. Whereas in a AP, it is like, you are very close. If I want to give you best example, AP is like a selfie. It's like a selfie. You remember in a phone, you take a selfie. You are very close to so the person who is taking the selfie's face will be larger than the person who is standing at the last. That is divergent. You understand my point. Whereas in a studio, if you take from a distance, everybody's face will be perfect. So that is PA. So I can give you a number of examples, but sufficient for you to know AP versus PA because cardiomegaly, size of the vessels, apparent positions of various structures can be a factor that influence you. This is not a problem for an adult physician, but definite problem for a pediatrician when he's interpreting the x-rays. And most of the x-rays are done in infancy. And by infancy, by default, there is a cardiomegaly in the sense that chest is small, and also AP makes it further cardiomegaly. Did you understand the point? It's not about cardiomegaly. It also means that a part of the chest is swallowed by the heart. Only I can see less lungs. A radiologist in the Felsen book, if you ask me, it is written that only 2/3 of the real lung you can see on an X-ray. 1/3 is really not seen. That is because it is behind the diaphragm. It is behind the heart, behind the ribs. You can't see. So from 2/3 of the available lungs, you have to make diagnosis of complete three-third of the lung. That means full lung for the disease. You have to evaluate. And there is a radiological limitation. This limitation is further accentuated by the fact that it is an AP film and an expiratory film and portable film and a supine film and an uncooperative child. Did you understand? So these factors are very, very important. Maybe it will appear like I'm talking like a conventional radiologist, but if you don't know these factors, you are going to get into serious troubles of making overdiagnosis or underdiagnosis in a chest X-ray. Clavicles appear over the lung fields in a PA view. They appear above the lung field apex in a supine film or a PA view. Scapulae, most important is scapulae will be away from the lung fields. This is the cassette of a, what you call, cassette. And in a PA, you will embrace like this. You understand? Many of you, if you don't know, you visit a radiology room, then you will know. No, you will spread your scapulae when you take a PA view, and you hold the cassette close to your chest. Can you see here? And your arms will be like this. No, you will separate your scapulae. While separating the scapulae from the chest, you will see more of lung fields. I'll show you the scapula border. There is a scapula border. Whereas in a AP view, scapulas come close. That means up to the hilum. So therefore, what did I say in the first remarks of mine? Any shadow on a bonish tissue will appear more exaggerated. Now, if I tell you on a scapular shadow, if you have mild pneumonitis, it appears as a moderate pneumonitis for you in that sense. Moderate density pneumonitis for your visual impression. Therefore, any background shadow will actually affect your interpretation. Posterior ribs are distinct in a PA view. P for P, you remember. Anterior ribs are distinct in a AP view because this is the one which faces the X-ray first and gets in. Whereas it is the last one that faces the X-ray. That means the number of X-rays that are stopped by an anterior ribs is more than the number of X-rays that are stopped by the posterior ribs in a AP view, and therefore that is what is the shadow that you see. Why anterior ribs are distinct in a AP than a PA. I hope all of you have understood, and I'll proceed. Okay, you don't need to know too much about this, but just I will tell you in detail. So in practice, you can forget few points that I have told you and then be prepared as a pediatrician just to receive the X-rays. Understand? Everything that I have told you, you need not by heart. You are not taking exams, I suppose. And therefore, you need not worry to remember every point. Now look at the AP common in infants. Heart and mediastinal appear magnified. I'm summarizing it for you. But why you need an AP? Easier for positioning, especially in sick children. Sick child cannot cooperate and often performed in semi-erect or supine position. PA is a standard view, requires cooperation, better evaluation, gives the perfect sizes of not just heart, lung, all structures. Next, I'll come to the rotation. This is the most important point. If you ask me in pediatrics, which is the single factor that troubles you most is the rotation. And I saw in WhatsApp groups, many of you have posted the X-rays and they are all rotated, and you start discussing so much but not discussing about rotation. Once there is rotation, stop discussing about the text. We are not specialists in making interpretation of oblique X-rays, and for that you should know oblique X-ray anatomy. You understand? You cannot know the anatomy of an anteroposterior anatomy. You have read and understood and interpret an oblique by extrapolating. It's just impossible. If you want, nobody prevents you from reading an oblique anatomy. You read an oblique anatomy, become the master of it, start interpreting oblique X-rays. I have no problem. But till that point of time, you should not. You just concentrate on the lower figure. This is how a perfect alignment will look like. The chest can be rotated to the right. This is right rotation. This is rotation to the left. Now, how do I identify? Now, this is, you focus on my cursor. This is anterior and this is posterior. That yellow marks, dots will give you X-rays. X-rays pass through, and on the posterior there is a film. You understand? Either here or here there is a film. Okay. If it is a PA, there is a film on the anterior or a cassette, or if it is an AP, there is a cassette at the back. Correct? That's fine for me. That's not a problem for me. Now here the issue is that these clavicle medial ends will appear on a chest X-ray. These are the medial ends of the clavicle. Can you see? This is the medial end. This is the medial end of the clavicle. Now there is also spinous process. Can you see the spine and the spinous process? And the spinous process also appear on the chest X-ray. And this is the best chest X-ray example which shows you both the things. Now please understand the medial ends of the clavicle here, the medial ends of the clavicle here, and the spine. The spine should be equidistant from the medial ends of the clavicle if the chest X-ray is not having any rotation. This is perfect example of non-centering. These are the spinous process. Can you see? And this is the medial end of the clavicle. This is the medial end of the clavicle. So that means to say this patient is rotated to the left because the right end is exposed. If you rotate to the left, the right gets exposed. See, you see my both hands. Let's say these are hilum of the patient. Now this is perfect. Rotation to the left. That means the hilum on the right side becomes prominent. Rotation to the right. Then my right hilum becomes prominent. Left hilum overlaps over the end on. Left hilum becomes end on. The right hilum gets spread over the lung fields. Now I go further. Now, what it means is that whenever you take the chest X-ray, check for the rotation, and then the medial ends of the clavicle with the spine should form isosceles triangle. That means to say these two arrows should be equal, and that can be seen on a two-dimensional picture as equidistant from the clavicles. What happens to misinterpretation on a rotation? I'll just give you one or two. Dr. Bora, I will repeat about vascularity again when I discuss about LRTI. Now here, misinterpretation of rotation happens. For example, I'll just see my chest now. One of my chest becomes more anterior or posterior based on my rotation. Did you understand? So that means the unilateral hyperlucency or hypolucency also depends on rotation. Please type U if you have understood. That means to say you bring your hila and vascular structures more end on, and you hide the hila. Or hila means vessels and spread. And Dr. Vikrit, I'm going to repeat for you. Please understand. Now, like this, if I turn, now I turn to right, look at my left hand. This is hilum which is radio opaque. This is hilum which is not radio opaque. And my right lung appears dense. My left lung appears lucent because it is taking the hilar away towards the midline. Away from the midline, it appears more lucent. Am I clear to you? Please type U. I'll repeat. Whenever you rotate this way, this is the left lung, which appears more lucent because all the radio opaque structures come closer to the center. Here, all the radio opaque structures spread to the periphery. This can be mistaken for foreign body. I have seen bronchoscopies being done for want of perfect rotation. Type L if you like this, because you should not suspect foreign body by unilateral hyperlucency without checking the rotation. How important these basics? But my point is that, sir, perfect unilateral hyperlucency, what is the 3-year-old? Do bronchoscopy. That patient travels 100 kilometers by paying for taxi and in a distress for a bronchoscopy. And once a person goes to bronchoscopies, how can he say bronchoscopy is not required, go back? It's impossible. Because you would have a setting of suspicion of a choking and you would have taken. You understand my point? I'm not telling should be the point for doing a bronchoscopy or not doing a bronchoscopy. I'm coming from X-ray point of view only, not from whether you should do bronchoscopy in a suspect case. That's not the point. If suspect, you do bronchoscopy. The second point is, even it's not only rotation like this and like this. Now I am taking a horizontal rotation. You understand? This is horizontal rotation. What if the rotation also becomes oblique? You know, astigmatism. Remember, in cornea we use that word. Now this is a perfect example of an X-ray which is rotated in various ways. It's not horizontal, and this can give rise to kyphoscoliosis. That is one part. But second problem is not kyphoscoliosis. The second problem is the chest on one side can shrink vertically or open vertically on the other side, shrink horizontally, vertically, or now imagine in not just horizontal and vertical, you imagine all dimensions. Did you understand what I meant by rotation? Rotation, you think of 360-degree rotation, not just 180 degrees. In that, there will be various problems related to interpretation. Did you all understand? Please type U. It is not left rotation to the left and right. It can be above and below. What is the best example of above and below rotation? I'll give you the example of above and below rotation. Can anybody type? It is supine versus standing. When you supine, it is rotation backwards. Understand? When you stand, it is upright. When you bend forward, it is rotation forward. Did you understand the concept of rotation? This is very, very important for you radiologically interpret and understand that various structures inside may appear more lucent or more radio opaque. This fact should be taken into consideration when you make a diagnosis of pneumonia. I have been seeing many. I'm sorry, Dr. Nagmani, there is nothing like a vertical rotation that is available uh, in any textbooks. But I'm trying to tell you, you look at the X-ray number B. Here the problem is like this. A child may be in various position. Somebody may be holding the hand here. Somebody may be pulling the legs here. You understand? The child can be positioned in like this, like this, like this, like this, like this. You understand? All of you, up and down, I'll explain to you. Down means nobody takes the X-ray like this. They take the X-ray like this. But backwards, if you go back, that becomes supine film. Because the source of the X-ray is like this. It becomes a rotation backwards. That means you tilt the body like this. You understand? So that's the point of rotation. Now here, how CT scan is better than an X-ray? It defeats the rotation. CT scan defeats the rotation because multiple X-rays come from all around. It is like shooting from all around. You are duck, bullet from all 360 degrees. You take the images, X-ray images, and computer and the software computes all these images and makes a perfect image. You got the point. The advantage of a CT scan over a chest X-ray is that it defeats all these points, because there is an inbuilt software which is going to interpret an image in this way, in this way, in this way, in this way. 4 to 5,000 images around will be computed, and it depends on the generation slice. I think you have heard spiral CT, this type of CT. What does that mean? You can take spirally going X-rays, you can take conventionally rotation. In various ways you can chop. I think those of you cut the vegetables understand the way you can cut cucumber or an onion can be done in various ways. How many of you have cut the onion as ring plates, chopped sides, small breaks? You understand? I can give you the best examples. So please understand the way you cut the vegetables, you can cut, slice the images and interpret the images. That's what we mean by spiral CT, conventional CT, high resolution CT, etc. Basically, CT is an X-ray. It is computed X-ray. In the olden days, we had what is called as tomography. Tomography means there was an X-ray and a film, dagak. It used to do like that. At the point of the fulcrum or the focal point, if you have forgotten physics, it's called focal point, or in a camera, what is called as focus. So your lesion should be at the point of the focus, and you take that computing images. This was called as tomography. X-ray tomography. It was conventional, which was improvised with the computerized images. It's called as computerized tomography, and that is what we meant by CT. Did you like this explanation of the CT and origins of CT scan? Please type L. Just I will take a glass of water. I go further. No, why you need to know all this is, don't get scared. I'm not trying to teach you radiology, or not, nor I'm making a radiologist, but my point is that when you see an X-ray in the wards, know all these limitations, then if you know this, then you will know the perfect indications for CT scan. People ask me, sir, what should I do? Should I do a CT scan or repeat X-ray? Now, please don't ask me that question again. Should I have to do a CT scan or should I have to repeat X-ray? If you think that by repeating the image twice, your problem is solved, you repeat the X-ray. If you think that you have to repeat 10 images to 10 X-rays to solve this problem, do a CT scan. Did you all understand the indications for CT scan? Please type yes. If you think that by just making a lateral, your problem is solved. If you think that I'll just do one more scan or one more exposure of the X-rays, my problem is solved, then fine. Don't do multiple X-rays. If you think it's an indication for multiple X-ray exposures, that's a perfect indication for scan. Please, I have been seeing many textbooks, many journals, many conferences where people say, these are if you suspect an intrathoracic lesion, you should do CT scan. It is not like that. An intrathoracic lesion cannot be qualified by one-dimensional image, because it may require surgery, it may require intervention, it may require more interpretation. You want to see the capsule, you want to see inside, a CCAM, for example, or a calcification inside, or a tumor, or for example, a mediastinal node with, uh, caseating necrosis. You want to interpret. It is impossible without knowing, and therefore you need an X-ray. So I just wanted to take out from you AP, PA, rotation, all these problems. The solution is CT scan, but it comes with a package that it is having radiation disadvantage. I'll just get into that little later on. Now, shift of the trachea and mediastinum can mimic a pathology, especially in the mediastinum, in the paratracheal area and paramediastinal area. And you would love this line from me. This is a line from Felsen textbook, which I love forever. And today I want all of you to read that Felsen textbook. It is not very difficult. 400 pages, can't you read? He says, Hilum is the graveyard of radiologists. And to me, I'll tell you till date, Hilum is a graveyard for all of us. Whether it's hilar adenopathy, prominent hilum, less prominent hilum, is there a node? Do you all agree? Hilum is a graveyard. Please don't say no. If it definitely it is a graveyard for all of us. Lot of problems we have in and around hilum. And if you take trachea, it's fine, lungs fine, cardia fine, borders fine. It's not a difficult situation. Whenever you come to hilum, that's the area. And today I'll spend another 10 minutes extra on hilum. If all of you say yes at the end, I will give you perfect interpretation. But my only point is that you can have lunch while you are doing. Don't try to leave the workshop for the sake of it, because you learn the gray areas, and that's the area which you want to get in. You definitely, all of you, I'll not disappoint you. I'll teach you more about the hilum subsequently. But why I brought this point is because hilum is more a graveyard if there is a rotation. Hilum is more a graveyard if there is a rotation. Therefore, in this context, I'm talking about hilum. Now, I want you to consider inspiration and expiration. Now look at this X-ray. Look at this image, which is showing that inspiration and expiration. What is that you are seeing here? Now look at that inspiration. Inspiration just does not mean expansion. See, look at my ribs, my hands. These are the ribs. What I was thinking for many years is inspiration means expression. Inspiration, expression. It is wrong. I will now show you what is inspiration. Are you seeing that image? Did you understand? Okay, I'll just now show you perfect inspiration expression. This is what I meant by inspiration expression. What is that you are seeing there? I have drawn a line on the lower part of the slide. You see the slide. You see a large amount of expansion of the chest happens in the lower part of the chest than upper part of the chest. And many pathologies, although X-ray gives you 50-50% image sharing for upper half of the chest and lower half of the chest, the pathologies are 75%, 25% for lower half versus upper half. That means it's Dr. Charul, it's not about bucket handle movement. It's also about your cutoff. You see your mind. One half of your mind interpretation goes for upper half of the chest X-ray, while the pathology is really in the lower half. Dr. Charul, do you agree with me? We spend more time seeing the upper half of the chest X-ray than the lower half. I would put other way around. Do you agree? Please type EAG, all of you, if you agree. We start from clavicle, upper lobes. Hardly anything is there except thymus. And whatever we pick up, we are behind that. But real problems happen in the lower half. And a large amount of lower half is hidden. Hidden behind the diaphragms. It is beneath the heart. It is beneath. And that's why whenever you take the X-ray, you don't find, sir, ye kya hai? X-ray is not helping. How the X-ray will help you? Because you don't know what is X-ray. That's the problem. And I will tell you, lower half of the chest is best seen on lateral X-ray. Now you have to type yes if you want to really agree. Now I have given you the logical indications for lateral X-ray. Please don't say I want an X-ray lateral. If you think that you take the upper half and lower half is the point of evaluation, take a lateral X-ray. Here you don't have to go to CT scan. Now, did I give you a beautiful comparison as to when to take a lateral X-ray and when to take a CT scan? This is an important dilemma. All of you face. Please don't tell me no. I have faced, and if I have faced a problem, you will also face. This workshop is not about just telling you something, giving you collection of X-rays. It is about giving you an insight and an approach as to how you should go about ordering an X-ray. This is very, very important for you. If you think that, okay, upper half is fine for me, the lower half, I have a doubt, I can't see, there is some diaphragm, there's something here, take a lateral. It clears. And CT scan is available in only few places. But a person where an X-ray is available, you also can take a lateral. In the lateral, suppose your perfect lateral doesn't come, please do not worry. Don't worry about it because you already have an AP with you. See, when you have two images, it is easy for you to make an interpretation. Don't interpret lateral alone. See the lateral and AP, AP and then lateral, lateral and then AP, and correlate. Please, all of us don't correlate. Like you have rotation in an AP, you also have rotation in the lateral. It won't be perfect lateral. Did you understand my point? So therefore, you must take a lateral X-ray. Now I'll come back to the point of inspiration and expiration. Now why I was diverted towards that indication for lateral was because of upper half and lower half. A film taken in inspiration only will give you more details of the lower half. Because the lower half opens up and in a given cassette you can see. I'll just show you how it is happening. This is the expansion of the chest. Please note, I'll give you 15 seconds of time and look at that. This is inspiration, expiration, inspiration, expiration. Am I done? Now look at the anterior ends of the ribs. Inspiration goes up, expiration comes down, inspiration goes up, expiration comes down, inspiration goes up, expiration comes down. When it goes up, you count more number of anterior ends of the ribs in a film, in a window. I'll just show you what I meant by that. Suppose if I take an X-ray, I'm just cutting it to show that an X-ray is taken now. And in inspiration, you can see more number of anterior ends of the ribs. This is what I meant by anterior ends of the ribs. 1, 2, 3, 4, 5, 6. You can see up to 8. You can see. You understand? Whereas in an expiration, you can see only 3 or 4. Did you understand? Please type yes. An inspiratory film will have more anterior ends of the ribs. I will tell you the applications of this also. Please don't worry. I'm not going to teach you only conventional radiology. I'm going to teach you what it means in clinical practice. Don't worry. Now, I also wanted you to focus on the cardia. Now, let us assume the gray area is the cardia. I'm sorry, that is actually the chondral position of the ribs. Costochondral. This is chondral portion of the ribs and sternum. But let us assume that is the cardia. What happens to the shape of the cardia in an inspiration? The cardia is like this, becomes like this. Inspiration, expiration. Inspiration, expiration. Look at my hands. Inspiration, expiration. Inspiration, fine. Expiration, cardiomegaly. Inspiration, fine. Expiration, cardiomegaly. Inspiration, fine. Expiration, cardiomegaly. Did you understand how to know a film is inspiratory or expiratory, and also about the cardia? Now I'll come to this. You can see these two films. The upper one is inspiratory. I'll count the anterior ends of the ribs. 1, 1, 2, 1, 2, 3, 4, 5, 6, up to 7. You can see cutting the hemidiaphragm. So this is a very good inspiratory film. Look at the lower one. 1, 2, 3, 4. By the time it is coming to 5th only, it is almost meeting. This is a mid-expiratory film. So you can have perfect inspiration film, perfect expiration film. But a child can be mid-inspiratory, closer to the inspiratory, closer to the expiratory, mid-expiratory. You understand my point? Mid-inspiratory, expiratory. It can be in any phase of respiration. You have taken a photo, tuck, click, X-ray, shoot. At that point of time, it can be closer to an expiration or closer to an inspiration. It may not be perfect expiratory film also. Now, you are only categorizing the X-rays into either inspiratory or expiratory. I think you should be telling me, sir, it is more towards inspiratory film, more towards expiratory film. May not fit into definitions of inspiratory and expiratory, but still the findings are very, very important. Do not make a diagnosis of cardiomegaly. Can you all see apparent cardiomegaly on an expiratory film and perfect size? So don't comment on the cardia in any expiratory film. Now the problem, sir, why you are talking so much about inspiratory and expiratory? I'll tell you what happens in a child when you are ordered an X-ray. Will the child cry or will the child cooperate? Please try. It will cry. And cry is an act of expression. Most of them will shout, cry, oh, mommy. No. You understand? All these are the positions expiratory. So a child by default, by God's grace, it is going to get into expiratory phase, whether you like it or not. And you should get acclimatized to interpreting an expiratory film in such a way that you should know the limitations and then interpret an expiratory film. Because you can't go on ordering too many films. And let me also tell you, a child with a respiratory distress, the expiration is often prolonged in a viral infections. In viral infections, is it that the child inspire well? There is air trapping. Did you understand? It by default it comes to a phase of expiration because expiration is also prolonged than inspiration. Most often than not, you start clicking the expiratory phase of the respiration. I'm coming to a clinical application. These two are important. One, cry, and second, ear trapping, which is the most common thing that happens whenever we as busy practitioners order an X-ray, and X-ray often comes in expiratory phase or findings of expiratory phase you should know. I'll go further. This is how you identify an inspiratory and expiratory. And expiration is not just about shrinking anteroposterior alone, even shrinking above downwards. Also, it gets, I told you, like horizontal and vertical rotation. Inspiration and expiration are also, okay, somebody is asking how to identify anterior and posterior ends of the ribs. I'll just show you 1 second. This is anterior ribs, my cursor, and this is posterior ribs, right? On an X-ray, I'll show you. This is pointing downwards is anterior, like this is posterior. Posterior, I'll trace a rib. Posterior rib, posterior rib, posterior rib, posterior rib, anterior rib. Okay? Posterior rib, posterior rib, posterior rib, anterior rib. That means it is just like Emmanuel. Did you understand? Anterior and posterior ribs, right? Now, anterior ribs are the ones which are counted. You can also count inspiration, expiration based on posterior ribs. You have to add 2. 6 anterior ribs or 8 posterior ribs should be seen in a very good inspiratory film because posterior ribs are placed higher up. You need more number of posterior ribs to say an inspiratory film. That is difficult because you look at this expansion of the chest. That's why I posted this video. If you see there, the movement of the anterior ribs is more than the movement of the posterior ribs. And therefore, in a good inspiratory film, it is easy to identify more number of anterior ribs than the posterior ribs. I'll go further. Now, these are the 5 differences between an inspiratory and an expiratory film. Now, this is important for you in interpretation. Bronchovascular markings are crowded in a expiratory film, and you always make overdiagnosis of an inflammation. Inflammation means in the chest more bronchovascular markings, and you always say there is increased vascular markings and there is probability of pneumonia in an expiratory film. Did you understand how the overdiagnosis of pneumonia happens? And diaphragm is highest, and diaphragm highest means the lower half gets hidden. Now look at the expiratory film. I gave you the example of upper half and lower half. Now look at this. Look at the cutoff. The hidden part, the lower half, is really hidden in an expiratory. And here I will not be able to tell whether there is more or less of pneumonia. You understand where it puts us in real difficulty in an expiratory film to really make a diagnosis of pneumonia. Because in pneumonia, there is a pathology. And in an expiratory film, there is a physiology that is causing radio opacity. That's very, very important for us. And it is not just only the position of the ribs. It is that the entire chest gets shrunk and there is more vessels per square inch. There is less vessels per square inch. More vessels per square centimeter, less vessels per square centimeter. Did you understand the point? And that's what exactly happens. And I will not comment on rest of the findings here. Rib cage, lung volume, all these points becomes too much for you. That is mostly for radiologists, not for us. But if you want, I will tell you in detail. But suffice here for us as clinicians that in our real life situation, one, we take expiratory films. Second, there is increased bronchovascular markings. Third, there is an apparent cardiomegaly. And fourth, in the lower half, we miss a lot in an expiratory film. Whether to repeat in an inspiratory film or not. How to differentiate between an inspiration film and an hyperinflation. Hyperinflation is hyperinspiratory. You understand, the findings are on the other spectrum of inspiration. In a good inspiratory film, ribs are oblique. In an hyperinflation, you will see ribs also become horizontal. And even there is pruning of the vessels. The diaphragms becomes flattened. There is microcardia in a hyperinflated film. It is not microcardia, it is actually exaggerated thoracic volume, which pushes and shrinks the heart. This is exactly what are the clinical radiological findings that you get in an emphysema in an adult. Okay, right. Now, is it that an expiratory film is bad? I'll just show you. This is an expiratory film, and this is an inspiratory film on the left. When you took the expiratory film, there was a further air trapping, and it helped in detection of a foreign body. Please don't think expiration is a disadvantage. Expiration is an advantage in a foreign body. That's because the air cannot go out because of ball valve mechanism. In inspiration, both the sides are expanded. But in expiration, the air goes out from the other chest but doesn't go out from the. This is a very good sign for foreign body. In fact, this is one of the confirmatory signs for foreign bodies on an X-ray or any intraluminal obstructions. Please remember, this finding can be a detection of all that I would say is that there is localized air trapping. We don't say foreign body. Please understand. Radiologically, we say localized air trapping. Cause of localized air trapping, one of the common situation is foreign body. And in pneumothorax, what happens in a pneumothorax? When you expand, the pleural line goes to the thorax. When you breathe out, the pleural line falls away from the chest, thorax. Now, this is the lung margins in a pneumothorax. In an inspiration, they go up, but in an expiration, let's say my right hand is pneumothorax. Now, what happens is inspiration fine, but in an expiration, it collapses. Right pneumothorax. My right hand, this is my right hand. Sorry, whether you are seeing on the left or right, I will not be able to know. This is my right hand, and this side is pneumothorax. I'll just show you what happens in inspiration and expiration. Inspiration fine, expiration. Inspiration fine, expiration. Inspiration fine, expiration. Did you understand the interpretation of pneumothorax? This is very, very important to in clinical practice. I'll just show you here the lung margins. Can you see here how lung margins can be better seen? This is a good inspiratory film, and in an expiratory film, you can see the lung margins better. I'm sorry for the film, but there is a thin line margin here, which you can identify only in expiration. And it's not just the margin is seen better on an expiration. It is also that the rest of the lung becomes little dense. When there is a collapse of the lung because of pneumothorax, that lung becomes more radio opaque. And therefore, the margin is seen better with contrast of the air that is seen in the pleural cavity. Did you understand? Therefore, you get a lung margin in a pneumothorax. This was one of the MCQs that I have given to you. Identification of the lung margin is most important for diagnosis of pneumothorax. Now, why do you need an inspiratory film? A good inspiratory film means it will spread everything. See, when you want to see something, you will tease them. It's called teasing. Or when you want to see something, you will actually spread it out and see. You don't see in a shrunk way. Do you all agree? And inspiratory film means it will spread the lung very well. It will spread intrathoracic very well, that you can actually interpret very well. This is most important, and that's why you need an inspiratory film. What it means to a pediatrician. This is the summary of inspiration and expiration. Better visualization of lung fields, essential for detecting small effusions or infiltrates, allows accurate lung heart evaluation. Children often cry during exposure and therefore an expiratory film. It mimics consolidation. If you don't exercise caution, helps in detecting foreign body and pneumothorax. The problem is not pneumothorax and foreign body alone for us. That's okay if the child cries for me. But here the biggest problem for me is consolidation. Overdiagnosis of consolidation or pneumonia happens in an expiratory film. Be very, very, very careful. Exposure. Exposure, I don't want you to see film number 1 and 2, but see the boxes below. 1, 2, 3, 4, 5, 6. Now, 1/1000th of a second, if you take a photograph, this is how the photograph comes. 1/100th of a second, 1/10th of a second exposure, 1 second exposure, 10 seconds exposure, 100-second exposure in a photo. You expose the film, a photograph, click. The clicking time. If the clicking time is too small, you don't get any clarity of the picture. If it is optimal, you get some clarity. And further, as when you click more and more, it becomes overexposure and the details are lost. The clicking time should be optimal. Did you understand what we meant by exposure? Dr. Nagamani, I will explain how it mimics consolidation little later on. Now look at the exposure here. What it means is that, look here, this is a perfect underexposure. Underexposure means you expose for very less time. Very short exposure time. This is prolonged exposure time for the X-rays. The soft tissues will get burnt out. The spine appears very, very prominent. And here, there is a less load of X-ray because of shortest duration of time. So everything becomes opaque because the dose of the X-ray that is offered is too less because of reduced exposure, and that X-ray gets obliterated onto a film, and therefore you see more whiteness. You see more whiteness in an underexposed, more darkness in a overexposed film, and perfect exposure means you should be able to see the spine behind the heart. If you see only spine but not heart, that means it is overexposed. Why this is important, I'll tell you in subsequent slides. I'll give the example of an underexposed film. Here you will feel that suddenly there is increased bronchovascular markings and a pneumonia. Here you will feel nothing I can see. Now I'll go further and show you that there was actually, after perfect exposure, can you see the spine behind the heart a bit? Is a perfect exposure. Actually, you can see a collapse behind the heart in the same film. Here also, now if you go back, it was seen. Now, can you see here again? I don't know if you could see here, but very, very difficult. It requires extraordinary imagination by a person to see that kind of collapse, but very, very difficult. But here you can perfectly see the collapse. And I'll go further. You can see the margin of a pneumothorax in a perfectly exposed film. This is the margin of a pneumothorax. But if you overexpose, you cannot see. So exposure can make differences in the visiting. Now, this exposure is not a problem in digital X-rays. You can adjust the exposure. You can't adjust inspiration, expiration because it is child dependent. But exposure, you can make an image more whiter or more darker. But a problem of adjustment is that you should know that it is adjusted. Otherwise, if you adjust, you can make a pathology, physiology, and a physiology pathology. You can cheat a person by I can become more fair by photoshopping, which is digital disadvantage, but also an advantage. You understand my point? So therefore, all of you please remember what are the characteristics of a perfect exposure. Perfect exposure means lung details should be seen, and this is a perfectly exposed film. A bit, at least one half of the spine you should be able to see. You understand? And the lung markings appear appropriate, and this is overexposure, this is underexposure, and this is perfect exposure. Am I done with that, Dr. Nagmani? I'll come back to inspiration and expiration. Inspiration, this is one anterior ends of the ribs. Nagmani, I'm explaining for you. 1, 2, 3, 4. This is an expiratory film. You understand? Exposure is correct, but this is again happens to be an expiratory film. Because it is expiratory, there is cardiomegaly, and I can see the low, actually lung margin. If it was inspiratory film, Actually, these two would have become closer. I might not have been even able to look at the collapse. So there are always ifs and buts about everything that you take. It's a dynamic thing. X-ray is a two-dimensional, one-time flash photograph of the dynamic image, three-dimensional image, and therefore there are limitations. Okay, agreed. Next. Underexposed, I'll just give you film appears too white, can mimic consolidation, even same as expert. Here, you will feel that there is a consolidation here. If you are not taken properly, may obscure lung markings, collapse can be missed, poor penetration of mediastinal spine, especially I told you, Hilar is a gray area, and diaphragm borders and heart borders become indistinct. And overexposure, film appears too dark, actually there is excess of visibility of vertebrae behind the heart. Actually should not be able to see the lower half of the vertebrae behind the heart in a perfect exposure. It mimics early, it may miss infiltrates, or even an effusion can be missed on this, because effusion means what? Effusion is a fluid that obliterates X-rays. If you put more X-rays, it will actually uh, penetrate through the even the fluid also, and therefore it appears like an air. You understand what I mean by how it can miss an effusion? A thin effusion is there around the chest. Don't think of effusion only at the base. It's in the entire pleural cavity, and if you shoot more, you can overcome the resistance of the fluid to the X-rays, and X-rays can appear normal. This is a small factor, just passing by remark. Motion blurring can happen. That all of you are camera mobile, you take the camera and you will delete these images. You understand? This can also happen in cases of X-rays, and you should be able to recognize them. And it is easy to recognize. I don't think I need to explain this, but you have to reject the X-ray. Now, problems of portable X-ray. One, it is supine. Second, it is AP view. Third, uh, it is like overexposure. Fourth, expectation of an intensivist is the lung, but what you can get is not the lung, and there could be secondary involvements. See, for example, you admit a pneumonia, you have secondary cardiac involvement, and there is a respiratory distress. You want to know the cardiac component, etc., and you ask for an X-ray, and you don't get anything. Please understand. Third, you can't go on repeating. It is too cumbersome. Patient intubated, and you take an X-ray. You have to move him out. You understand? For those of you who have taken, you will understand. And there is chances of overinterpretation of a uh, portable X-ray um, in a in case of a portable film. What I mean by overinterpretation, all of you will be taking PICU rounds. Once an X-ray film is there, you leave the patient and go to the view box and go on discussing about the X-ray, but not about a patient. You forget physiology. You focus on anatomy. These are the problems. And first X-ray is taken and somebody is not happy. He repeats another portable. He will not say, I want a PA or I want a CT. You understand? So often it is better to take CT scans in ICUs than to go on repeating portable films. Second film is not better than the first one and is not going to give you progress of the disease. Disease progress physiologically faster than the anatomy. Please remember in ICUs, don't go on repeating the X-rays. I see X-rays are done morning, 8 o'clock, 9 o'clock, 10 o'clock, 12 o'clock. They will burn the pneumonia radiologically than actually by antibiotics. So it is very, very important for you to understand repetition of X-rays in the ICUs, exercise caution. Dr. Saluja, I think that overexposure and underexposure is enough for you. Please remember, it is not in your control. It is a radiological control. The technician has to be good. And what comes to you, you just comment on the exposure. Don't worry about trying to regulate the exposure from your side. And if it is underexposed, beware of these things. That's all. Don't worry about too much. But I am more worried about rotation. If you ask me take home message, AP film, portable film and rotation are very, very important for us in practice than even the exposure in and other things. You understand? They are little too technical like blurring, etc. So let's not become too much of radio technicians in our interpretation. But my point is that how it influences us in our day-to-day practice. Now I'll come to some artifacts. Artifacts do exist. This is hairband. You should know this is a hair band. And why not this is a mass or a fluid? No, the point is that they go and extend beyond the thorax. Any shadow, for example, here tufts of hair, it can be a vessel, but point is that it goes beyond the chest, crosses the chest. Any shadow that crosses the chest is an artifact. Point number one. It could be a stab wound. You understand my point? It could be an implant, pacemaker. I mean, for example, like pacemaker, it could be a pen in the pocket or your buttons. So many things. Sometimes you may or may not be able to remove certain things. You understand that X-ray is often taken in a hurry. So you must be remembering, and they can be the problems in especially interpretation. This is how an hairband appears. You understand artifacts are important. What is the diagnosis here? Anybody can type miliary buttons. Okay. For want of time, I'll just go to the answer. This was the answer. This is what was seen, an artifact. Did you get the point? That's how it was there. It is from the dress. Right. Okay, good. Now sometimes you will mistake a nipple shadow in an adult for a solitary pulmonary nodule. This is not for pediatric. I'm just completing. Please don't mistake me. Uh, I'm passionate about radiology, therefore I'll discuss adult radiology also at times. But see here, this is a solitary lung nodule, perfectly on my cursor. This is a nipple shadow, and you should see a breast shadow. This is a nipple shadow. These nipple shadow appears similar as a solitary pulmonary nodule. Here there is no breast shadow, and position of the nipple is very important. And often they may or may not be bilateral. That is because the positions of the breast when you take an X-ray film may or may not be bilaterally symmetrical to produce a perfect bilaterally symmetrical nipple shadows. So be careful. And nipple shadow appears only when it is end on perfectly, because it is going to be radio opaque. It's fine. This is just a point in an adolescent or an adult X-ray. Sometimes you might be even interpreting one of the teens X-ray, and then you should be very careful. Is the foreign body inside or out? Now look here. This is where you don't need a CT scan. This is the foreign body. You want to know the location? Take a lateral. It is now in the esophagus. You understand? This is the trachea. And behind the trachea is esophagus. This is esophageal foreign body. Here I can't know whether it is a pendant or not. Also, I will not know. You understand? Now it is intrathoracic. Now here it is extrathoracic. Same thing, but here extrathoracic. These are buttons, right? And you can easily make out. Now I'll come to the next concept called as silhouette sign. Now this appears as though this man is holding the aeroplane, and this is what I meant by silhouette sign. And look at the silhouette sign here. What it means is that even though it appears like this man is holding aeroplane, you know that he is not holding the aeroplane. And that for impression is because you can easily make out that the man's hand and the aeroplane are not in the same plane. You look at my hands. This is my right hand and left hand. Are my right hand and left hand are in the same plane, right? Yes or no? Same plane? Yes, correct. Right? My right hand and left hand are in the same plane. Now I'll give you a picture. Is my right hand, left hand in the same plane, although they are overlapping? They're not. Did you understand? Did you understand? I'll just show you 1 minute. I'll just show you now my right hand and left hand. The picture in X-ray is overlapping, but they are in different planes. That means my right hand ulnar border is seen. Ulnar border is seen. My left hand ulnar border is seen. Ulnar border is not seen. That means my right hand, left hand are now silhouetted. If two anatomical structures are in the same plane, their borders are not seen. They merge each other, and this is called as silhouetting. Now, silhouette sign means when they are in anatomical different planes, you can easily differentiate by knowing the margins. This is exactly what has happened here. You can see the margins of his hand distinct from the plane. That's why you are able to say he's not holding the plane. Okay, now I'll go to the X-rays. This is an X-ray. The top X-ray shows that this is the pneumonia, and the right cardiac border is not seen different from pneumonia. That means right cardiac border and the pneumonia are in the same plane, and right cardiac border is anterior and right middle lobe is anterior. Therefore, it is right middle lobe pneumonia. Whereas in the lower film, what you are seeing is that right cardiac border is distinct from the pneumonia. That means this pneumonia is not in the same plane of right cardiac border. Therefore, this is right lower lobe pneumonia because the right cardiac border is distinct. Did you understand the silhouette sign? Please type yes. Yes, sir. Okay. One of you. That's okay for me. Is there or any of you want me to repeat? Fine for me. Right? Now I'll go further. Somebody wants me to repeat. I'll repeat. No problem. The two anatomical structures in the same plane. This is my right middle lobe and this is my right cardiac border. If they're in the same plane, this is right middle lobe pneumonia. Whereas this is pneumonia, and if this pneumonia is behind the right cardiac border, it will appear like this. That means that you can see the cardiac border, and when you see a shadow like this, that means to say that pneumonia is behind the heart. Retrocardiac pneumonia. If it is retrocardiac pneumonia, it has to be lower lobe pneumonia, because lower lobes are posterior. You understand? This is a lower lobe pneumonia. This is a middle lobe pneumonia. You can think of silhouetting of left cardiac border. You can think of, suppose some mass silhouettes the arch of the aorta or abdominal aortic margin. That means it is posterior. You can see the arch of the aorta and the aortic margin distinct from the mass or a lesion. That means the lesion is anterior to arch of the aorta. Am I done with that? Did you understand? You can take silhouetting for clavicle, you can take silhouetting for ribs, you can take silhouetting for various structures. Any two structures, if they are indistinct, that means they are in the same plane and same radio density. Why we say pneumonia and cardia? Because what is there in the pneumonia? Radiologically, fluid. What is there in the cardia? Fluid. Did you understand? So therefore, there is an overlap and no overlap. That is all that you need to do. How does silhouette sign helps? It helps to localize intrathoracic lesions. There is a perfect chapter on in Felsen textbook. How to localize intrathoracic lesions. Where are they? Whether they are anterior, posterior, from an X-ray. Please read that chapter. It's an excellent chapter as to how to localize intrathoracic lesions, and one of the important sign I have picked only one sign, that is called as silhouette sign. Now I have talked to you about thymus, and let me complete about thymus. This is the thymus across. Dr. Nagmani want me to repeat aortic arch. Aortic arch is posterior. If a shadow silhouettes aortic arch, it is in the same plane of aortic arch. That means it is posterior. If aortic arch is seen distinct from the radio density, that means it is not in the same plane of the aortic arch. It has to be anterior, because aortic arch is the most posterior structure, not the arch, sorry, abdominal aorta. The part of the aortic arch is anterior. Aortic arch goes like this back. You understand? I mean to say abdominal part of the aorta. You understand? Anterior part of the aortic arch is anterior. It takes some left ventricle, goes back. You understand? So whichever part you are describing, based on that, you have to look at the silhouette sign. It is not about anterior posterior. It is anterior or posterior to the anatomical structure. So you take the anatomical structure as a baseline to decide the plane of the lesion. So nowadays, this much of exercise is not required because you have got CT scan. You understand? But otherwise, if you wanted to get the maximum interpretation from the X-ray, you use the silhouette sign. Now, this is the thymus, 2-month-old thymus, 7-month-old thymus, 16-year-old thymus. Thymus shrinks with age. Mind you, This is one structure that can be differential diagnosis of anything in the chest. Remember thymus, because if you don't remember thymus, then you are in soup. See, now it looks, this was apparently later proved to be thymus than a pleural effusion. No, I'm just presenting to you. But here there is a problem. It could be pleural effusion plus thymus. That was what was told to me. I went through this case in the online, and it was a case of minimal effusion with a thymus. But the problem is, it is not that the fluid is present in the rest of the lungs. And here you can see it's called as cardiothymus. This will give you boot-shaped appearance of a phallus, and you can get a lesion like looking like a lymph node or looking like a mass. Anything can appear. This is also a part of the thymus that is seen, looking like atelectasis. It can look like a. See, my point is, please remember, it is not necessary. My images that have been shown here may not mean exactly what I said. I was trying to search the images for my explanation. I have taken some of them. But my point here is that remember that the thymus can closely mimic many intrathoracic lesions. There is something called Sales sign. How do you identify thymus? Then when you say it can mimic, I need to identify whether it's thymus or no thymus, isn't it? It's not fair if I tell you it can mimic and then close. For identifying, there are two signs which I will tell you. A Sale sign means this is a Sale. This is what we meant by Sale sign. It can be on the right or left. It is easy to identify a thymus. This sign is very important. This sharp cutting. You understand? This is called Sale sign. And usually right-sided, normal finding, not a pathology. Then its second thing is called wave sign. Can you see the wave sign here? I have shown you the wave here, and this is called as wave sign. This wave sign happens because of rib notching. On the ribs, when there is pressing, it will produce that wave counter. You understand? This is very important for you to know, and this is thymus. The third sign is notch sign. This is called as notch sign. Can you see the notch here? It is called notch sign. It is different from the Sale sign. Sale sign refers to this edge L, whereas the notch sign refers to this notch, V notch. You understand? This is not seen in intrathoracic masses, lymph nodes, etc. They don't cut like this. Whether it is a lymph node or a thymus, this notch sign is important. If you find a notch sign, it is thymus. But however, when you have a doubt, you can always take a ultrasound. Now, I gave you, and that's it about thymus. I will come back to the thymus later on. Now, look at what is happening on a lateral film. This is the lateral film, and this is the lateral film where you will see is a coin in the esophagus. Now you see this is anterior posterior view of a foreign body, and in a lateral film you can identify it is intratracheal than in the esophagus. I mean, it's not important, but sometimes the lateral helps to you, especially in radiopaque lesions. You wanted to know where is the lesion, stab wound, surgical. It is more not for infections, please understand, but sometimes it helps. And I gave you the perfect indication for a lateral film. This is a perfect lateral film that you would see. Now, how to interpret a lateral film? All of you remember that there is something called as in the space we use the term. Is a term called as what is the point in the solar system that is called black hole? It is called as black hole. What do you mean by black hole? Black hole means it appears pitch dark in the center. Left main bronchus will produce a black hole on end on. I'll just show you in a lateral film. Can you see here? Left main bronchus. I don't know. I'm not getting a perfect film here. Can you see here? And can you see here? Left main bronchus. This is the trachea and left main bronchus. Left main bronchus produce an end on hollow view. That is the perfect lateral, and that is a point for you radiologically to say where is what. It's very easy for you. And why not right main bronchus? Because right main bronchus is in line with the trachea. Left main bronchus is an offshoot from the trachea, and in a lateral you can get an end-on view. Did you understand why left main bronchus? Because left main bronchus, this is the trachea, and left main bronchus, right main bronchus. You understand? It can produce an end-on view, and and Charles, why you are confused? This trachea, right? Left main bronchus, and right main bronchus goes down. Right main bronchus is in line with trachea. So in a lateral film, only left main bronchus can give you end-on view, not the right main bronchus. That's called as hollow, HOLO, hollow sign, or whatever you find in a solar system. You know, it's called a black holes. It appears like that. Do not worry much about it. But that means you need to understand above and below. That is where they can identify the hilum in the. That's how you can identify the hilum in the lateral film. Now I will look at the lateral film. It contains the following features. There is a sternum, retrosternal space that is called anterior mediastinum. There is cardia, and there is a posterior mediastinum. Dr. Satyajit, I'll show you in not in this film, some other good film hollow sign. Don't worry. I'll just download one later on in the break time and just show you on hollow film. Or one of you can download one perfect lateral film from an internet and show hollow sign. It's very easy. Please type, you will get it. Left main bronchus end on in a lateral view. Just Google it, you will get it. It's not a big thing, but you can easily see. But while I'm discussing, it's difficult for me to download, go out and download. But let me continue my discussion. Easy for you. Now look at this lateral X-ray, which is important to me. Anterior mediastinum, middle mediastinum, and retrocardiac, that is posterior mediastinum. Please focus on the points that I'm going to tell you. You start looking at the mediastinum. Retrosternal is often lymphoid tissues, thymus and others. Posterior mediastinum, often the masses that you get are consolidations or neural origin, neuroblastoma and other things, or even skeletal, etc. Understand? This is the middle part is mediastinum, and whatever you get is often hilar. All structures, vessels, lymph nodes, etc. in the hilar. So this is very, very important for you to understand the mediastinal lesions. I was trying to tell you that I'm going to tell you more about hilum and other things. And one of the important factor is the mediastinum. Now look at this spine from above downwards. It is dense, radiodense, 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 radiolucent, 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 radiolucent. Did you understand? Why it is more radiolucent down is not because spine is more and more radiolucent down. It is because the lungs are hyperinflated. Or I would use the word, normally the lower lungs hold more air than the upper lungs, and therefore the spine becomes more and more lucent as you move from above downwards. Suppose I will show in X-ray, second X-ray, the lucency of the spine is not seen. That means, as you trace down, that means there is pneumonia. Why this lucency here is not seen here in this yellow is because there is pneumonia. And I have put you this orange margin. Can you see the margin of the pneumonia here? I'll just show you 1 minute. Slowly concentrate, 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 concentrate. Can you see here the margin of the pneumonia? I don't know. Could you see? Please type yes. Parallel to this. Could you see in your mobiles? Because I can see on the laptop. Okay, fine. Now imagine this patient taking an AP or a PA film. This is what I meant by missing. Now this is the diaphragm that you see in a AP film. I will just put this down. This, you take your eyes here. This cuts here, and this goes retrocardiac also, and definitely you will miss a pneumonia of the lower lobe. This big pneumonia you will miss if you take an AP film. Or I would say sometimes, the lower half appears a little more dense than the upper half and you miss. This is the importance of the lateral. Please understand, suppose the child is not doing well despite a normal X-ray, you can consider the option of adding a lateral. I'll just show you the third lateral. Please focus from above downward. Spine, 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 spine becomes more loosened. Suddenly you will see a fluid. This is a vertical ascent. In an AP or a PA film, we call it lateral ascent. Here you can see a posterior ascent of a pleural effusion. And this orange one will give you the fluid level. This is not pneumonia. This is fluid. This third one is a fluid. And this is pneumonia. And don't worry, relax now. I will teach you how to differentiate between a fluid and a pneumonia later in my next session, or I would say in my next slides. But right now, focus on the point that look at here. Suddenly, there is radiopacity of the spine. Here, there is a gradual radiopacity of the spine. Next, you have to identify two hemidiaphragms, the right and the left. One of the ways you can identify right and left is by knowing the stomach bubble. I'll show you here. This is left hemidiaphragm because there is a stomach bubble. This is the right hemidiaphragm because there is no stomach bubble. This is one of the easier ways to identify. There are multiple other ways. Please read about it because I'll become too much of a radiologist if I start teaching you how to identify hemidiaphragm. Remember, there are two diaphragmic shadows. One of them is right and then another one is left. And based on that, we identify right lateral or left lateral, or it is labeled also. Now, I'll come to some kinds of applications. Now, let's see. This is a 9-year-old child with fever and cough. What is your diagnosis? Normal, abnormal. Please only type that. Normal, abnormal. All of you type normal or abnormal. Please don't hesitate. Don't worry at all. Feel free. This is a workshop. This is where you have to write what you feel like. Good. I'm getting many of you are writing normal. No problem. Hyperinflation, somebody read okay. 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 Now, what was your problem? Somebody started inspiration film. So, suddenly don't jump. I distracted you. Don't jump. I distracted you. I distracted you. Don't jump. See, everybody should start. Now, at least Dr. Lata, couple of you, some people have logged in with the name of Oppo and all that. I can't see your names. But let me tell you, please start seeing trachea, two bronchus, left heart border, right heart border, hemidiaphragm, lung fields, thorax, position, exposure, rotation. You understand? All these things start seeing. At least, okay, I will not ask you to be too much on it, but at least it should quickly pass through your mind. 1, 2, 3, 4, 5, 6, right? Now I'll go to what was the problem with this X-ray. When the lateral was taken, this was the finding in the lateral. Now you tell me, what did we miss? What did we miss? Round pneumonia. It was missed, perfectly missed. It is the same patient. This is the pneumonia. And the child was running fever and cough. How it was missed? Now we come back here. Actually, there is pneumonia here. Only to get missed. You understand my point? It is so subtle and it get missed. And my problem is, sir, is this also pneumonia? Don't keep on asking me like this, sir. Can this be pneumonia? Can this be pneumonia? For all this, you need to become familiar with the anatomy. This is what I was talking to you about, becoming familiar with the anatomy. You understand? Don't get scared. It is not very difficult. It is easy to master. Now, don't leave WhatsApp groups now. Please don't leave WhatsApp groups now. I'll explain to you 100 times. But let me tell you, you bear with couple of messages that come because of elections and otherwise. These groups will continue to discuss. You start posting your cases. Let the group people start reacting to those films. They will react. This is this, that. In WhatsApp, you see quick responders. Don't go by that. Please, if anybody types 5 or 8, 9 lines, this is a AP film, exposure is fine, inspiratory film, no rotation, levocardia, both hemidiaphragms normal, I can see a fluffy shadow, margins are indistinct, the radio density matches with that of the fluid plus air, therefore it is probably consolidation. Looking at the shape, it is round pneumonia. No, it is not possible to diagnose round pneumonia, otherwise this may not be in the phase of consolidation, it may be in the phase of congestion. This is very yes. What prompted to take left lateral in this patient was because it was reported in a journal. Please understand, this was not that somebody picked it up. What they have missed later on, they have taken the lateral only to prove that we can miss on the lateral. Please remember one thing, none of us are perfect, we can all miss, and we can miss because it is X-ray. If I How many of us know photoshopping? You understand, you can always cheat another person by giving a film. X-ray is after all a film, not a patient. And it is a film diagnosis that you are making, not a patient diagnosis. That is a limitation. And we don't understand that. However much, how many number of conferences I must have spoken. Even then, the same mistakes happen because we get carried away by us by the busy clinic. Please remember this. Don't worry about the diagnosis, but remember that you can miss. That's enough for me. This is again an X-ray. And what is the diagnosis here? Anybody can type. Okay. Don't worry about being impulsive and getting distracted. Don't worry. Right now, I don't want you to type all the 10, 15 exposure, okay, and all that. Straight away write diagnosis. Sale sign, one good. No, that's okay. View and all, Dr. Monica, don't write. Thymus, okay. Collapse. That means between two pediatricians, there is a confusion between thymus and collapse that makes me worried. Did you understand my point? That's fine, but makes me worried. I'll tell you how to differentiate a thymus from the collapse later on. Okay, collapse, pneumonia, thymus, three confusions. No problem. Everything fine. I agree with all of you. Now here, I was not bothered about either the collapse or the consolidation. I was worried about what did you miss. I will just show you the next click. You will have the answer. All of you will have the answer. I will not speak. Now tell me what's your diagnosis. Anybody? Same film. Till collapse. This is a case of rickets. And why the rickets was missed? Because all of your focus was on right upper lobe. Right upper lobe, let me collapse thymus. I'll discuss at the end. Don't worry about it. I've got n number of cases to be discussed today. I'll discuss them at the end. But you look at what is happening here. There is bulbous end. What was the problem here? The problem here was that we were not looking at the complete reporting of the chest. Look at here, should go up to skeleton. And when you distort the film, no, when you distort the film like this, then you can see better. Now, what happened was, whenever we see like this, we see cardia, lungs, correct? We are often tuck taken to that. When you put this film like this, then you will always see the skeleton, even fracture of the ribs, etc. When you want to see, don't hold the film like this, hold the film like this. Often you can make out. It can happen in battered baby syndrome or even sometimes rib lesions. Always, once you see a film, don't stop. See, and then close. Understand? Make a habit. That's the message. Okay, I'll just go next. There are pros and cons of digital X-ray versus conventional X-ray. Adjustable contrast, quick acquisition, electronic storage and sharing, repeat, lower repeat rates. You can have reduced radiation dose because you can adjust and see. Cons are digital X-rays requires huge investment, not available in every taluka place. It requires an infrastructure depending on electricity, etc. The advantage of a conventional X-ray is low cost. Every nursing home can have a permanent record. Nobody can manipulate it. The cons are limited dynamic range, I can't adjust, long processing time, difficult storage, cannot be shared online. You can't take a picture of a filament and share it online. High rates of repetition and exposure. Okay, these are important. So digital X-rays are quick, adjustable, shareable, lower radiation, high cost, IT dependent, while conventional X-rays are low cost. That is the advantage. High spatial resolution, time consuming, storage issues, and higher repeats. This is a summary. Don't ask me, sir, should I take a digital or a conventional? If I take a conventional, know that these are the disadvantages. If you take digital, know that these are also advantages and disadvantages. And when you take a digital X-ray, ask for them. You ask for adjustability. We never ask. Ask the radiologist to send a film, making it darker or lighter. He will send it to you, and you can actually see. Now, diseases and chest X-ray. I've got another 20 slides or another half an hour of discussion. You've been listening to me from past 2 hours. You never realized. Correct. Now, I've got attendance here. I will take the attendance now. Do you want a break or you want to continue? Because you are all eating and you are comfortable at home. Please give me an idea, sir. You want a break means I'll give a break here or break after 15 slides and go for live discussion. Shall I continue? Please type no. I don't know. Because don't leave the group. If you want a break, I'll give the break. I mean, if your mind is getting blocked, if you need a break, I'll continue. Many are telling me to continue. I'll go, no problem, no problem. I'll take continuation, no issue. If you're feeling bored anytime, please let me know also. I don't mind. But don't leave and then learn half because you have to completely learn. Okay, fine, no problem. I'll just continue. Now, here, actually, for understanding an X-ray, you need 3 years of MD. What we have done is, we have understood the normal variations of the X-ray and how they will influence our interpretation in diseases. Diseases are pathology. And what is a pathology? A pathology can be a solid, it can be a tumor, it can be a fluid mixed with air, it can be a pocket of air. You understand? I'm putting it in pneumothorax, consolidation, some tumors, masses, some skeletal issues, etc. Got my point? Cardiac. Basically, an X-ray will not understand a pathology. It will only give you the radio density. It will give you whether it is more dense, less dense, in between density and lucency, more radio dense than rib or less radio dense than heart. It will give like that. If you find any shadow equivalent to the density of the radio density of the heart, that means it is fluid. Or it has same radio density of the blood, a blood vessel, for example. Now, if you are you facing network issues or am I facing network issues? Dr. Monica, you are facing network issues, don't worry. You can again, those of you face problems can appear for one more workshop on Tuesday, Wednesday, Thursday. I'll teach with the same enthusiasm. I have no problem. Okay, no issues, right? Now, in diseases, what happens is you have to focus on the densities and you have to match the density with the existing densities. Something same density of the bone is very dense. It could be calcification. It could be a bony part. You understand? Whereas something most common is fluid collections, either effusion, pneumonia, etc. You understand? And all of you can attend any number of times. I have no restriction on any one of you in attending any of the sessions. So if you have some densities and in that case you see more or less compared to a fluid, you have to make conclusion. Now, are you all ready and charged up to apply it in diseases? Please remember, X-rays don't give you a diagnosis of pneumonia or not. You should be. I will be very happy if you type air. I will be very happy if you type fluid. If you type air plus fluid, which is common in pneumonia, only fluid, like that. Let us make a radiological diagnosis. Please do not jump to anatomical diagnosis in all my subsequent discussion. However, still I'll be asking you to just type what you feel. From that field, you should reach up to air plus fluid. Okay, that is the theme of this next 20 slides. Now, what is this? This is consolidation, and I don't have to ask you why, because all of you know it is right upper lobe consolidation. It is right upper lobe consolidation because there is heterogeneous opacification of the right upper lobe. And why not it is right middle lobe? It is because there is no silhouetting of the right cardiac margin. Therefore, the right upper lobe is like this. It occupies most of the anterior part of the chest. Right upper lobe is like this. You understand? It's called as anterior lobe. Middle lobe is also like this. And right upper lobe and middle lobe are like this. I don't know whether you understand my point. Can you see right upper lobe and middle lobe? This is middle lobe, right upper lobe. Can you see now, understand why that right upper lobe pneumonia is up to this point? This is right upper lobe pneumonia. Now what is this? Is this right upper lobe pneumonia? Answer is no. Because it is not coming up to here, there is collapse. This is pneumonia. Can you see my hands? And this is collapse. And collapse has a margin. Now why this is collapse? And how did you say it is collapse? That's very, very important for me. I'll show you both the X-rays now. Now look at why this is a collapse. First of all, in collapse, there is a reduced volume. You can see the reduction of the volume. Why not say? I'll come to that point. There's reduction in the volume. Now, further, tight margin, and there is crowding of bronchovascular markings. See, look at the bronchovascular markings here. Sometimes you see here a bronchogram, but if you don't see an air bronchogram here, because there is collapse. These bronchovascular markings are all radiating like this. I mean, there is no vascular marking seen distinctly here. You understand? They're all crowded. That is number 2. Number 3, most important is, what about the middle lobe? There is a compensatory hyperinflation of the middle lobe. Why do I say middle lobe hyperinflation? The ribs margin is, look at the distance between the ribs on the right side and distance between the ribs on the left side. Do you agree on hyperinflation? And look at the radio density, more lucent, less lucent. Did you understand? Do you agree with hyperinflation? Please type AG. It could have been a thymus with a Seil sign, but thymus will not produce hyperinflation of the middle lobe. Now, did you understand how to differentiate between a collapse and a thymus? Thymus will not produce any deviation of trachea, structures, anything. It is a benign bunch of grapes. Thymus is a benign bunch of grapes that will fit into the thorax. I'll repeat, don't worry. Now, here, this is consolidation and this is collapse. Signs of the collapse are crowding of bronchovascular markings. You will see a collapse margin, and because there is loss of volume, it is compensated by the neighboring structures. Like this middle lobe here is, there is a compensatory hyperinflation. Why do I say compensatory hyperinflation? For 3 reasons. 1, it is more radiolucent. 2, there are less number of bronchovascular markings. That means it is having more air than vessels. Number 3, the ribs horizontal, diaphragm is flat. Look at the diaphragm here and diaphragm here. It becomes more flat. May not be perfect. Did you understand? It depends on the volume or amount, physical volume of hyperinflation versus physical volume of the collapse. If the upper lobe collapse, see, I will tell you, I can't see, Nagmani, I agree with you, there is no increased bronchovascular marks. I'm telling you the signs of collapse. It is not here, right? Crowding, no, I can't see bronchovascular markings here, Dr. Charul. I will just show you one of the increased bronchovascular markings little later. Wait for me. Now here what I'm trying to show is there is loss of volume, there is compensatory hyperinflation, which is making me a collapse. There is a margin, right? There is shifts here, not in this film. Sometimes you see shift and drifts of fissures, trachea and mediastinum for collapse. See, have you not seen mediastinum getting shifted to left, right, etc. in collapses? Or sometimes even the hilum gets pulled up in case of fibrosis of the upper lung. That is collapse. Fibrosis and collapse of the upper lobe. Hilum gets pulled up. You understand? Like this, hilum, see my shoulders. Hilum will get pulled up like this or down. You understand? Based on the, pull-push effect or dragging effect, whatever. Now, what I'm trying to tell is, don't focus on too many things, but understand a shadow is not just a consolidation but a collapse if there is a compensatory hyperinflation. Consolidation itself may not produce compensatory hyperinflation. Now, these findings are not direct. They are indirect based on the volume of the collapse. Now, if you look at the right upper lobe collapse, it is a small volume of lung. Lower lobe collapse means big volume of lungs. Did you understand my point? So therefore, be careful. Whenever you are looking at, you should be having that physics in mind. What is the volume that is affecting the drifts, shifts, or the amount of compensatory hyperinflation? But right now here, let us summarize. I can differentiate between a consolidation and a collapse by compensatory hyperinflation, loss of volume, crowding of markings, shifts, drifts of trachea, bronchus, crowding of ribs, or paralleling of ribs. More crowding means more and more obliquity. Paralleling means emphysematous. You understand? Based on all these things, I can make out whether this collapse or not, which is important for me. However, in practice, in children, the airways tend to collapse more so in newborn and infants, and therefore, often in practice, the consolidation is associated with collapse, and we call it as collapse consolidation. So you can have more radiological signs of consolidation or sometimes more of collapse. You can have mix up of both signs of collapse and consolidation. I'll go further and I'll teach you, don't worry. This is again another one which shows the thymus but not the collapse. Look here, there is a consolidation here and there is a collapse film here, and why it is a thymus but not a collapse is because of the following signs. Can you see the wave sign? Can you see the sail sign? Yes. Can you also see the wave sign on the other side? Yes. Here it is not seen. Did you understand? And do you see the compensatory hyperinflation here? Answer is no. Last, most important, look at the density. And thymus gives uniform density. This is entire thing is thymus. Uniform density. Whereas there is heterogeneous opacification in a consolidation. In a collapse also there is heterogeneous opacification, but there is more density because it is collapse. All these structures are in one pack. That means it has to be more radiodense. But this density is not as uniformly more dense. Okay, if you want to say collapse. You understand? Thymus physiologically isodense and spread. This is how you get thymus. Now, please type yes if you could understand how to differentiate a thymus. Trachea will never shift in case of thymus. Thymus is one structure which will never displace any intrathoracic structures. Please remember this point. Thymus is a friend. It is never a pathology. It's like bunch of grapes. I don't know. Have you been ever on a bean bag? Bean bag means I have to download and show you. Bean bag. I'll just show you the image on the Google. Give me a second. Thymus is like that. It fits in perfectly into a bean bag. I'll just show you a bean bag on images on my mobile right now. Just see in my mobile a bean bag. This is the bean bag. Can you see the bean bag? All of you can see. Type OK. Thymus is like that. It fits in the chest. Wherever it goes, it fits in there. It will never cause displacement of any of the intrathoracic structures. Please remember, understand. Don't try to by heart. This is very, very important. A thymus is comfortably fills in whichever area that it is available to you. That's why it's called cardiothymus. It can come on the cardiac border. It can come on the right, left. More often, it comes onto the right. Right. Now, what is this? I've given you consolidation, collapse, and a thymus. What is this? Is this thymus or collapse? Okay. Now I think you are all confused. I'll just explain to you. There is thymus here. This is thymus. Margin is seen, right? This is collapse beyond thymus. After the thymus margin is there, there is collapse. Why? Because can you see here compensatory hyperinflation? There is compensatory hyperinflation here. Because there is compensatory hyperinflation, I can be happy with only thymus. It does not mean if a patient has got thymus, he should not get collapse. He has both thymic and collapse shadow. Can you see both here? There is an existing thymus, but the shadow is basically collapse. And I can see the thymic shadow. So don't report it as only thymus. This is a mistake often we do in practice. Because I'm asking you are seeing so closely. Routinely when you say, thymus. You understand my point? Do you all agree that we jump to conclusions on an X-ray? I don't know. Uh, Today in the workshop, you have been little made up your mind to see an X-ray, and therefore you are like this. Tomorrow, when you go to what, suddenly you will come back to the square one and say, this is thymus. I can see the margin here. But you don't see closely what is beyond the margin. This is very important for me. Focus on compensatory hyperinflation. Very, very important sign. Now, not just this is over. Actually, let's look at the left lower lobe. There is a consolidation here, which is again missed. This is a patient who has consolidation of the left lower lobe, right upper lobe, collapse consolidation plus thymus plus compensatory hyperinflation of the mid lobe. This is the complete diagnosis, but often you can miss. Now, let me go to one point, that is Seil sign. Beyond the Seil sign, what you see is collapse bar consolidation, and that is number one. Number two is compensatory hyperinflation, and that's most important. Now, you want me to show how hyperinflation is here. Look at the density radiolucency of the two, and let's say this is 3. This is 3. This is more inflated. 2 is more inflated than 3. This is 3. My cursor is 3 and 2. Did you understand hyperinflation is seen? And also, can you see the ribs spacing, everything? Actually, for hyperinflation is a subjective diagnosis. You read textbooks, they'll give 1, 2, 3, 4 signs of hyperinflation. I'll come to that point. Don't worry. This hyperinflation is very, very easy to understand. What do you mean by hyperinflation? Vessels will become less, air becomes more. Alveolar sacs get distended. Vascular markings gets reduced. And because of the volume effect, you can see spreading of the ribs, shift and drifts of the surrounding structures, like it can press on the diaphragm, cardiac border, etc. You understand hyperinflation? Localized hyperinflation means air trapping. Generalized hyperinflation is what happens in most of the viral infections. This is localized hyperinflation. You can also apply rib counting area. Criteria that you, Nikita, you are very much correct. You can apply rib counting, and if you see more number of ribs in inspiration, you should see up to so many, but you see more than many, then you can say it is hyperinflated. Excellent. Now, what is this right upper lobe again? Here, what is this arrow mark showing? What is this? Is it thymus, collapse, consolidation? What it is? Please write the diagnosis. Everybody's writing now thymus, good. This is not thymus because there is a nasogastric tube here. Can you see? And this arrow mark, this is, there is a, here there is an, airway, don't worry about that. The second arrow mark shows nasogastric tube, and nasogastric tube is showing deviation to the right. Remember? No, not consolidation also. This is a mass. The reason for mass is because collapse with consolidation means you should get the signs of collapse or consolidation, which is not here. The displacement that you see cannot happen with collapse. In collapse, you can't get a push. You get a pull. You understand? Consolidation cannot cross the borders. Now, nasogastric tube is getting deviated, which means that there is something displacing the thorax. This is a rare case. Don't worry. This was a tumor, and because, or I would say it's a mass than just a consolidation. Consolidation is part of the lung. This is more than a lung because it is displacing. You understand my point? So therefore, this is a mass. Now I'll put all this together. You have understood now right upper lobe or right upper lobe area. This is consolidation. This is collapse. This is thymus. This is more than one and this is less than one. Rare, but it is a mass. So all of you are now trained masters of right upper lobe area because you are now comfortable diagnosing any lesion in the right upper lobe. Do you all agree? Type H, okay. I'll go after, I will leave the right upper lobe now and I'll go to other areas. Okay, all of you are comfortable. Don't worry, this is the first step. Now, I will close all the lobes by telling you that whatever rules you have applied in the right upper lobe, apply in the left upper lobe also. Do you think collapse consolidation of the left upper lobe is different from right upper lobe radiologically? No, but there is no trouble of thymus for you there. Same rules apply in the left upper lobe, left middle lobe, left lower lobe, right lower lobe, right middle lobe, etc. Apply the same rule. Now I finished all the lobes for you. Only problem was right upper lobe because there is thymus. And how would I explain to mass? Mass in the right upper lobe, same findings of the mass in the left lower lobe. Also apply the same rules there. It applies there. Next, I'll go further. Now, what is the difference between these two X-rays? Now I've come to high level of application. High level of application. Now here, X-ray 1 and 2, what is the difference? The point which I wanted to look to you is there is increased radio density in this film number 2. Do you agree? More dense. Now, can you all from tomorrow have in your eyes the radio density of a thymus? You can apply Seil sign here and then say it is thymus. But I want you to understand this point. This is the radio density of a normal thymus. This is pneumonia. That's important for you. Did you like this? Did you understand what I meant by this? Is something that you need to little bit. I request you to have some little bit of practice. Very, very important for you to differentiate between pneumonia and not collapse here. It's only consolidation because there is no compensating hyperinflation. But the problem is here is that little X-rays are not perfect. This is 1, 2, 3, 4 ribs. Okay. This is also 1, 2, 3, 4, 5 ribs. The good inspiratory films, I'm fine. But even though it is rotated or whatever, don't worry about it. But you can, by looking at the density, you must be able to make out. In pneumonia, you may or may not get air bronchogram. If there is no air bronchogram, that means airways are not patent. You understand? Airways may also be blocked. Now, what is the difference between X-ray number 1 and 2? Now look at, now here it is not as dense as this one. This is, can you understand heterogeneous opacification of the right upper lobe? Not much of compensatory hyperinflation. Here there is no question of hyperinflation. This is a mass. This is not even a collapse. I don't know how you could differentiate between a neuroblastoma and atelectasis. This requires a little bit more expertise or reading. This is where you would need a radiologist. Sometimes you treat a neuroblastoma as pneumonia, give vancomycin, ceftriaxone, then say it is not responding, then you would investigate. All these cases have been investigated by pediatricians. In the first feeling, they'll say it is pneumonia and then they treat. You understand? In the first place only, they may not be able to pick up a neuroblastoma. That's fine. But it happens in practice, you should remember. That's why I say persistent radiological signs investigate. That means we all miss. All of us miss. We should know that we can miss, which is very, very important. Now here, atelectasis means, it just means atelectasis is a word which is used radiologically for collapse. Collapse means it's like collapse. Atelectasis means it can be plate-like atelectasis, it can be segmental atelectasis, it can be lobar atelectasis. When we use the word collapse, we don't use the word collapse for a small airways. You understand? Segmental collapse we use, but plate-like collapse, we don't use those words. A better terminology like rhonchi and V's. You understand? Atelectasis is a better term used for collapses. Okay. Now, here This is an atelectasis, whereas this is a mass. My point here was not to look at the signs of atelectasis, but look at the radio density. I'll just go back to the previous one. Normal thymus, pneumonia, a consolidation bar atelectasis, and a mass. Are you able to understand the radio density part of it, which is something which is a high order thinking, just beyond that anatomical drift shifts, etc. You should look at the density proper. This is also important. Now, done with the right upper lobe. But are we done? Answer is no. This child's X-ray has a right upper lobe lesion. There is a sharp margin. There is a collapse. But what was missed? What was missed? This child was hypoxic, but right upper lobe collapse was not explaining the hypoxia. Actually, there is a collapse of the left lower lobe also. I don't know whether you can see. I just run my cursor. There is a collapse of the right lower lobe, which was missed. And that's the reason for disproportionate hypoxia on the X-ray. X-ray was showing small lesion, child was more sick. You understand? Then you should come back to the X-ray and see. Often you will not miss. Number one is compensatory hyperinflation. Number two is collapse. Number three is the again collapse segment, which is missed. So it's very, very important for all of us to understand that there can be more than one lesion. So don't stop interpreting an X-ray moment you see something. I remember my first line, distractor. Don't get distracted. Be cool and read. Don't stop interpreting an X-ray just because your mind stopped. You have to interpret X-ray completely. Now, I'll come to the most important session, and this is important for you. Nikita wants how it is a collapse. Okay. Actually, you can see this is the left cardiac border. And look at the cardiophrenic angle. There is a sharp margin here. And extend the same margin intracardiac. You will see the margin, but very difficult. But here you can see my cursor is right on top of that collapse margin. Actually, you need a radiological eyes. It's called bull's eyes, to identify the lesions. And it should be correlated clinically. Look here. Can it be a pad of fat? Sometimes when you take a supine film, what happens is, I don't know if you have obesity, then you will understand my point. Sometimes skin folds can come in an obese person who lies, not in children but in adults. Skin fold means, did you understand, like this? Skin can get folded and can give rise to collapse finding. Skin fold subcutaneously, a pinch of fold of skin and a subcutaneous fat can get folded onto a film when you lie down. You understand? Sometimes they can also give rise to some margins like this, but you should be careful. Okay. But they are often parallel. They don't radiate from the hilum. They're like vertical lines rather than radiating from the hilum. Whenever a margin is traceable to hilum, it is pathological. Don't stop interpreting an X-ray. Now, what is this? Please write the diagnosis. Don't worry about distraction now. You have the distraction in the discussion of workshop. I don't want you to say trachea, centrals, or well-exposed film. All those things, please don't write. Straight away write the diagnosis. No problem. Fluid. Pleural effusion, Dr. Rajkumar. Okay, so commit, no problem. Commit now. I'm not criticizing any one of you. All of you are correct. When you say effusion, you are correct, right? This is effusion, right? I'll go to the next film. Now, is this effusion or pneumonia? Please type. The second one. Now, pneumonia, right? Now, I'll go further. Now, the film one is effusion. The second is pneumonia. I think you please look at the radio density of the film one with that of the cardia. This cardia has a fluid. This is fluid. This is less dense than the cardia. I don't know whether you could appreciate that part. And therefore, all of you said pneumonia by default. You understand? And there is a lateral ascent here. Lateral ascent is not seen here. This is not just enough. Today I'm going to teach you something special, and you should give me a coffee if I come to your place, or you organize a webinar in your local branches, and I would explain this perfectly for all the other pediatricians. The most common mistake done for all of you, all of the persons, whenever you are diagnosing pleural effusion. I'll come to this point. which I'll explain to you now. Now, look at the arrow. Arrow from below upwards. As you move from below upwards, I have made your eyes radiological now. The radio density starts becoming less and less. As you move up, it becomes more and more lucent. I'm not going to repeat the explanation. Follow me carefully. As you move from below upwards, it is dense, dense, less dense, less dense, lucent, lucent, more lucent, more lucent, more lucent. Did you understand? Please type U if you have understood and correct. Now, why it is more lucent as you move up? It is because there is more air. Here it is solid liver. Where this date is there, no, there is liver. As you move upwards, liver is replaced by lungs. Because you know this is lungs and this is liver. I will show you lateral. Lung is like this and the liver is my fist. As you go upwards, you would see more of lungs and less of liver. And that is the reason for... 1 second, I'll just charge my laptop. Battery is low. I'm just charging. 2 seconds. I'll just put it for charging. It should not be like... I suppose it's fine. Now, what happens is as you move from below upwards, it becomes more and more lucent. And it becomes more and more lucent if there is air above the liver. If there is a fluid above the liver, it will not become lucent. Now, you see this pneumonia, which you said pneumonia. Now, I want you to put this arrow here in this X-ray. As you move from here, going on, going up, can you see more lucency? Still, there is liver here. Can you see this lucency? Please type A if you have understood. A. Please type A. There is lucency here in my arrow. That means there is air, but not fluid. So it is not effusion. It is not by looking at this you say effusion. You never looked at this radiological sign. That means no. Now for your understanding, I'll put here this fluid. This is very, very important. And look at this X-ray. Now, this was the first X-ray which all of you said pleural effusion. You trace from below upwards. Can you see that there is loss of lucency as you move from? It is not the lateral ascent that you should look for. It is not just the density. If you look from below upwards, the liver density merges with that of the fluid density, and therefore it is not pneumonia but effusion. Did you all like this? And you can diagnose radiological pleural effusion. Please type double L if you like. This is not taught many a times to the pediatricians to recognize pleural effusion. Really, I'm telling you, nobody teaches you pleural effusion. Everybody teaches you lateral ascent. Lateral ascent will happen only when there is large or moderate effusion. All of you have problems of minimal effusion, small effusions. Good test is ultrasound. But when you take an X-ray, the fluid collects behind the liver, in the recess or in the pocket. You understand? This lucency is lost. From today, don't tell me, sir, I couldn't diagnose effusion. This applies to both left side and right side. But why I took right side now? Is because there is liver. On the left side, there is no liver, so there is no problem for you. I took the right side there because there was thymus. Here I took right side because there is liver. There on the other side, there is no liver. There is spleen, but that doesn't cause so much of problem. So therefore, my dear friends, it's very, very important for it to recognize. Now you are certified masters of right upper lobe. Now you are certified masters of right middle lobe. Now, what is there on the left side? There's hardly anything on the left side. Left side is easy. There's only one problem on the left side, that is cardia. Now, I think you can all interpret chest X-rays very well now. This is effusion and this is pneumonia. Now, your eyes are changed. I would love to see your change of eyes now. The way you are looking at this effusion and pneumonia now is totally different now, my dear friends. Therefore, you can diagnose a pneumonia, you can diagnose effusion. You can diagnose if pneumonia is coexisting with effusion. Now, let us say I will take the example of this X-ray, and this density was like not able, no translucency as we move upwards. I would say, although the upper part looks like pneumonia, there is a small effusion below that. Sin pneumonic effusion, you can make a diagnosis, but you need a lot of patience, my dear friends. All of us are in very hurry. If you find any time, you save my number, message to me, sir, I have difficulty in this X-ray, but don't put me in trouble. Give me clinical inputs that I can make a diagnosis. Even I am a human being, I'll not be able to make. Mind you, in one of the conferences in Surat recently, we could diagnose not just, there was a confusion between whether the pen was in the pocket or there was a pen inside the chest. I could make the diagnosis in the open conference without telling me anything because of these signs which we applied and a lot of common sense. Actually, the child has swallowed a pen and has vomited. In that time, pen has perforated the esophagus and came up to the upper lobe, which we could diagnose only because of perfect application of your basics. Get your basics correct. If you want, I don't mind you appearing, reappearing for all the workshops on Tuesday, Wednesday. Let there be repetition. Instead of watching on YouTube, you start coming live. I might have forgotten a couple of points in the flow. I would repeat in the next, or I may tell more or less. Remember, please attend. Don't miss. Now, the point which I was trying to tell you is that don't stop interpreting an X-ray. Completely interpret. Now, this I will give you the next example, which all of you should give me coffee whenever we visit in future conferences for this concept. Now, look at what happens to an X-ray in an effusion. Now, these white things are the X-rays. X-ray passes through pleura and then lung and then come out, and this is the X-ray film. You understand? What you see on the top is an X-ray film. X-ray film. X-rays pass through the, whatever you see in an X-ray is an algebraic sum of whatever that resistances that follow for an X-ray to be reflected onto burning a film. You understand? Now, what happens is, pleural effusion is like a bucket in a bucket. A bucket in a bucket. Between the buckets, there is a fluid. And the inner bucket is the lung, outer bucket is the thorax. So, what surrounds the inner bucket is the visceral pleura. What surrounds the inner lining of the outer bucket is the parietal pleura. This fluid between the visceral pleura and the parietal pleura is the pleural effusion. Now, what happens when you take an X-ray? Now, let us say I take the X-ray at the side, outside the lung, in the periphery. The X-rays has to pass through. Look at my cursor. X-ray has to pass through fluid. And this is what happens on an X-ray density. Now, here, only 1 centimeter of the fluid, then large amount of air, then 1 centimeter of the fluid and comes here. So you will see a lateral ascent in an X-ray as an algebraic sum in a pleural effusion. It is not that the fluid goes on the lateral side and sits. It is a myth. You read Felsen textbook. I was delighted to know that now I will go back to this X-ray. Can you see this lateral ascent? Whatever you are seeing is because of this explanation. Please type L if you liked and understood. That means to say tangential X-rays pass through more fluid, whereas in the middle, they pass through less fluid. Suppose you take a lateral film, then same tangential, this is not, then you see anterior or posterior ascent. You remember I showed you one lateral X-ray. I told you I will discuss more during pleural effusion. I don't know whether you recollect. I was trying to tell you how do you track the spine from below upwards. There is a posterior ascent of the fluid. You want me to go back to that film? Posterior ascent. It is not lateral ascent. The ascent that you see are myths. They are because of resistance that is offered to tangential flow of the X-rays. All of you are now radiologists. I'm telling you, you are so good. Now we have understood the difference between a fluid and pneumonia. This is very, very important for you. I'll go further. I'm sorry, only workshops and long lectures can make you understand this. In short, Sometimes in conference, I was asked to speak about chest X-ray for 20 minutes. I'll not be able to even explain you only on pleural effusion in 20 minutes. So let's understand today. And probably all of you are eating and you are comfortable. And let me just quickly pass through the next couple of slides. Now you have understood. This is exactly what is meant by lateral ascent that you would get in a pleural effusion. And best way to know is ultrasound. Now you have to analyze. Let's see what is this. Is this an effusion? Now I have finished the right upper lobe, middle lobe. Now I come to the left side. There is a cardia. But the problem here is this is not an effusion because of one reason. I have given you the previous films also. Here the problem is, all of you should understand that here there is cardiophrenic angle and costophrenic angle. Look at the stomach bubble is seen well. That means it is not a fluid. The same way like liver. Here apply the same principle for stomach fluid, stomach bubble. The gastric bubble in the stomach is lucent and therefore there is no fluid collected in the recess. Fluid cannot collect in the upper lobe unless you have taken it in the supine position. And my dear friends, and therefore that makes this not an effusion but a mass or something. It could be pneumonia, collapse, whatever it is, but it's not a fluid. Don't put your tubes or needles without doing an ultrasound. Do this exercise for all the lobes and for all the lesions. I'll quickly run through in the next 5 or 10 minutes about the lesions that we see. I'll rush through them because for want of time, you have been listening to me for such a long time. And therefore, these are applications of viral lower respiratory tract infection. Viral lower respiratory tract infection is caused by many organisms. And you can also see some of the allergic diseases which mimic on X-ray a viral LRTA, like asthma and reactive airway diseases. You also have situations like congestive cardiac failure and uh, some normal findings due to thin chest wall. All this can cause what is called as increased bronchovascular markings. This is one of the common finding in viral LRTI. Now, what I meant by increased bronchovascular markings, I'll tell you next. But increased bronchovascular can be physiological because of thin chest. It can be because of fluid, because of cardiac reasons, or it can be because of viral diseases where there is increased vascular markings. Let me see how does that mean to me. Now, X-ray number 1 and 2. X-ray number 1 is normal vascular markings. X-ray number 2 is increased bronchovascular markings. That means these vascular markings are traceable up to the periphery. Here they are not traceable up to the periphery. You can't trace generally the vascular markings up more than 2/3 of the lung fields. And here I would just use this blocker for you to understand. If you can see the vascular markings beyond 2/3 of the lung fields, that means it is increased vascular markings. Or I would tell you that wherever you are not expecting the vascular markings, there if you expect the vascular markings, it is increased bronchovascular marking. It can be localized in localized inflammations, masses, collections, etc. Or it can be generalized based on the pathology. This is no confusion regarding increased bronchovascular markings. Don't tell me no, sir. You have understood now. Right? Okay. I'll go further. When they are matter of concern, generally increase that are symmetric and diffuse are benign. If it is asymmetric and localized bronchovascular markings, they are the points of concern and they could be suggesting pneumonia. If there is associated cardiomegaly, then increased vascular markings can be venous or arterial, increased pulmonary flow, or decreased pulmonary return, which can be because of cardiac causes. Causes therefore can be congestive cardiac failure, viral lower respiratory tract asthma, etc. So simple way to differentiate is symmetric fine, asymmetric pathology. In bronchiolitis or viral lower respiratory, you can see peribronchial cuffing. Can you see the peribronchial cuffing here? That you should see X-ray very closely. You will have these X-rays. All these X-rays are nothing. You will have this in your wards. You would have missed them. See, the peribronchial cuffing is because of inflammation and thickening of the bronchus. Next. This is the signs of bronchiolitis. What happens? You can see peribronchial coughing. You also see that the lower lobes, you remember that inspiration, expiration, which I showed you. Whenever there is air trapping, there is more air in the lower half of the chest. Now, can you see in bronchiolitis air trapping? What do you mean by air trapping? Air trapping means the lower half appears more lucent than the upper half. Very, very subjective, very difficult. You understand, in bronchiolitis, there is air trapping and hyperinflation because the lower half will have more air, and you will have more of flattening of the diaphragm, microcardia, pruning of the vessels as you move outwards. These are all indirect signs of bronchiolitis. You can also get plate-like atelectasis. Consolidation also is possible in bronchiolitis. Don't start antibiotics by X-ray. This is what I meant by air trapping, and you can see perfectly in lateral what I meant by air trapping. Can you see here the spine is very, very lucent? You understand? That means there is an air trapping. Don't take a lateral, but just understand from lateral. Now come back to AP. Then you'll understand there is perfect air trapping in the lower lobes compared to the upper lobes. Did you understand air trapping? That is very common in most of the viral lower respiratory tract infections in children. You must pick up this sign. Asymmetric air trapping is a sign of foreign body. In both cases, you will get wheezes. If you want to divide the upper half and lower half, I have divided it for you to analyze. These are clinically bronchiolitis pictures. You can see air trapping. You can see multiple mixing of findings. You can see here there is air trapping. You can see thymomegaly in bronchiolitis because the thymus is going to respond to viral infection. In viral infection, you can get lymphadenopathy, hepatosplenomegaly, and therefore thymomegaly also. Thymus also gets enlarged, and that's what you can confuse in terms of lower respiratory tract infections. In summary, early disease in bronchiolitis or viral infections, normal chest X-ray, which is what often you take. Mild disease, again, it can be normal chest X-ray. Bilateral wheeze, you can find signs of air trapping. Prolonged expiration, again, you can find signs of air trapping. Crepitation, if you find in a bronchiolitis, often in X-ray, you can see infiltrates or streaks, again, viral. Air entry, if it is diminished in one area, then in a chest X-ray, expect shifts and drifts. Did this clinico-radiological correlation? I will share with you all the slides. Don't worry about taking down screenshots, etc. I'll share with you PDF. You don't worry. You can also present. My only question is that, did you understand clinico-radiological correlation now? Okay, I'll go. I go further, and now I'm coming to a very important last point, and then 10 minutes or so I'll close. So look at this X-ray, and what you are seeing is interstitium here. This interstitium is a subtle interstitial disease which is often missed. Here, history will be chronic breathlessness or respiratory distress under evaluation. What has happened is this diagnosis is finally by CT. Don't worry about X-ray. But at the X-ray level, what we are having here is diffuse interstitium. And why it is interstitium, I'll come to you later. This is a suspense. Now I'll go to pneumonia now. Pneumonia, I will not show you pneumonia X-rays. All of you know pneumonia now, because pneumonia has to be differentiated from fluid, which I have shown you. Pneumonia has to be differentiated from thymus, I have shown you. Pneumonia has to be distinct from viral lower respiratory diseases, which I have shown. Pneumonia can be round, it can be conical, it can be segmental, lobar, sublobar, multilobar, broncho, alveolar, plate-like, peripheral, central, perihilar, parahilar, upper lobe, upper zone, lower zone, middle zone, pneumonia. In one breath, I told you all the types of X-rays. If you want, I download every type of pneumonia for you and send you in WhatsApp. But that's of no use, and that's what you have been discussing. Pneumonia is pneumonia. And treatment of right upper lobe pneumonia is not different from left lower lobe pneumonia. Both of them need antibiotics. And you treat the physiology, not the anatomy. Did I summarize in one breath entire pneumonia story for you? Please type OK. No, don't say you don't know how to diagnose pneumonia now. Please type OK. No problem. It's simple. Pneumonia is the simplest thing that you can diagnose. Actually, other things are difficult. That's why I'm spending more time on other things. Because if you know the other things, then the pneumonia becomes simple. If you don't know all these things I have told you, expiratory film, inspiratory film, everything, then the pneumonia is difficult for you. If you know all the things that I have told you so far, then the pneumonia becomes diagnosis of exclusion. Pneumonia, therefore, is a diagnosis of exclusion of the normal and interpretation of the abnormal. Okay. How good a chest X-ray for pneumonia? Actually, ultrasound is better than chest X-ray. You look at this figure, don't worry about the rest of the things. Sensitivity is good. That means it picks up. It is quite a sensitive test. But negative predictive value is 43%. That means pneumonia cannot be excluded by an X-ray. You can't say X-ray is normal, therefore the patient doesn't have pneumonia. This is a very, very common statement. Please type EAG. All of you have taken X-ray to rule out pneumonia. Even the PG is present to me. Sir, X-ray is normal, I have ruled out pneumonia. X-ray can never rule out pneumonia. X-ray can rule in pneumonia. But to rule in pneumonia, why do you need X-ray? You already made a diagnosis of pneumonia. So therefore, diagnosis of pneumonia is clinical. Because negative predictive value is low, that means you can't rule out, and therefore an X-ray is not a tool to exclude, but to include a pneumonia. And to include, why do you need an X-ray? Because they're already included by clinical evaluation. Now, which of these two suggest parahilar pneumonia? I'm not going to ask a quiz to you for want of time. You have been listening to me from past 3 hours. You never realize. Now, therefore, here what has happened is this perihilar expiratory film. This was a mass that was missed. This is a mass that is missed. Don't worry about it. But here there is a rotation which is again pushing one of the paratracheal hilum exposure. What happens in a real life situation? Again, you have to sit back, relax, and do 1, 2, 3, 4, 5, 6. Okay. Now, this is 1 and 2. Again, what is the difference between film 1 and 2? Now, look at the shadows here. Now, I am coming to looking at the markings. The 2 and 1, I'll just show you what it is. This 1 is having a pattern like this. This is interstitial pattern. 2 is a vascular pattern or an airway pattern. Air and vessels, air starts at hilum, airway, and go on dividing from hilum. Vessels also start at hilum and go on dividing from hilum. Did you understand? So either a branches of the airways filled with the fluid or arteries and veins, they radiate from hilum. What doesn't radiate from hilum is interstitial. They are broken lines. They don't follow Hilar to periphery journey from Bombay to Goa. They don't go. They go here and there. You understand? This is interstitial. Please type U if you have understood how to differentiate an alveolar shadow or a vascular shadow from an interstitial shadow. Please, got it now? In an X-ray, please understand this. This is very, very important for you. Very important because this is where you pick up the hypoxia and reason for hypoxia. Okay, I'll go further. This is, you have read in your textbooks, you have forgotten. Curly A lines, horizontal lines, curly B lines, which are vertical lines, C lines, which are broken lines. These are interstitial fluid in congestive cardiac failure. Understand? They are the fluids in between the acini or alveoli, which will appear like lines. And they don't radiate from the hilum. That's why we say curly AB lines are seen in the peripheral fields. Can you see A line here? I'll show you A line. Can you see B line here? B line. C line is like any line is a C line, which is not trackable and traceable. This is if you find findings like this, there is a fluid. If he is afebrile, it is cardiac. If he is febrile, it can be interstitial. You got my point? You have to make diagnosis of fluid in the interstitium. Next, interstitial shadows can be reticular. Reticular means like this, lace-like pattern. Now, why this is interstitial but not alveolar, if you ask me? That is because Now, what happens in an interstitial shadow? There is a fluid in between the air sac. There is an alveoli. In between, there is a fluid. That means the alveoli is patent. Airway is patent. That means the air in the airway gives double contrast. That means these densities appear more dense because there is a contrast of the air. That means like barium. Instead of pushing barium, here you push air into the lungs so that in the interstitium appears better. Did you understand? It's actually pseudo air trapping that happens in interstitial diseases. That means the air is perfectly going in and coming out, and the air inside gives a double contrast. Okay, you want to identify the colon in the abdomen X-ray. You can't identify the colon correctly. Suppose per rectally I inject around 5 liters of air and take an abdominal film. You can see the colon better. Margins of the mucosa of the colon better. That is what I meant by air contrast. You understand the air contrast? Please type yes. You understood the air contrast? I'll give the example of the colon. Colonic shadow. If I push air through the rectum, I can see the colonic shadow better. That is what I meant by air contrast. You understand? Now, same way in interstitial diseases, replace the colon with the bronchi. If I push more air in the airways, you can see interstitium better. They are like colonic mucosa. I'm just giving you a parallel. I'm sorry, I can't give you, that does not coming to my mind how best I can explain this. But don't worry about it too much. But remember that in bronchiectasis also, you see dilated bronchus and a vessel, signet ring appearance. That is because the bronchus is dilated. It appears in bronchiectasis like a round shadow or a parallel shadow and a ring. That means there is more air. Normal dilatation of the bronchus in a bronchiectasis gives you more air. That means that's why you call it as bronchiectasis. You can see dilated airways. You understand? That is what I meant by air contrast. Now I'll go. This air contrast can produce reticular pattern. It can produce a nodular pattern. This is nodular interstitial. In this film, you can see the air contrast much better than this film. This film versus this film. This is what I meant by air contrast. There is more air here because here there is more of reticular pattern. Smaller airways are involved. Nodular means larger airway, nodularity is there. You understand? So smaller airways are patent and they are giving more contrast. This is nodular. This is reticulonodular, but still interstitial. This is miliary, and miliary is interstitial. All of you will say miliary tuberculosis. No. Don't say miliary tuberculosis. From now onwards, you say interstitial miliary shadows. Differential diagnosis, one of them is TB. Why milia is seen well? The dots is seen well because of air contrast surrounding the milia. Please type L if you like this. This is aerogram around the milia that makes the milia to be seen as distinct, starry, punctate-like things. You understand? That is different from pneumonia. Please understand, this is different from alveolar shadows, okay? This is miliary. Now, you can have again interstitial shadow which appears like ground glass. Can you see this ground glass and why it is interstitial? Because it doesn't follow that Bombay to Goa, that hilar to perihilar pattern. Hilum to periphery. That is not followed here. Can you see? I have shown you ground glass appearance. You can diagnose pneumonias, ground glass pneumonias by just X-rays. Only thing is you should have the patience. And don't say it is motion artifact. This is perfectly taken film. And what you see ground glassing is because of the interstitium. Now, I'll show you again interstitial, and here it is vascular or alveolar pattern. Now, in a patient, in an point 1 is pneumonia, point 2 is ARDS. You will always say ARDS. But now you know double contrast of the air, and why these pictures appear distinct is because of the double contrast, and this number 2 is interstitial, while 1 is not interstitial. Remember all these right upper lobe, right middle lobe, I showed you are all alveolar shadows. They were not interstitial shadows. Now I am coming to the area of interstitial shadows, and why they are interstitial also you are understanding, my dear friends. I'll go further. That round, what you see is alveolar. The second round is interstitial. Now, I'll show you three boxes: alveolar shadow, alveolar shadow, alveolar shadow, and wherever you see more density, it is interstitial. It is not a rule that you should have either alveolar or interstitial. A patient can have a bronchopneumonia with worsening and then getting onto interstitial pneumonia, which is often a finding in day-to-day practice. Sometimes you can have a mix of the two, but you should be able to identify which part is alveolar, which part is interstitial as a radiologist. This is interstitial plus alveolar. You understand the point? Because there are mix of interstitial and alveolar shadows here. Now your eyes are changed. You are able to make out. Now this is interstitial. Understand? This is miliary. Now I'll come to the hilum. I don't know how much of patience you have got to listen to me on hilum, but let me not do injustice to you. You have been listening to me therefore. Any hilar lymph nodes are located in the hilar region. First, they should be located in this region. Then only they are called lymph nodes. They should not be present in anterior mediastinum. How you identify whether they're in different plane is by sill outing. A hilar node should sill out the hilum. That means sill outing means I told you, it should not be in front or behind the hilum. It should be sill outing the hilum. It is in the hilum. Other structures of the hilum, it should sill out. Sill outing sign I have explained to you. They are appeared as lobulated or rounded opacities. Lymph node cannot be any other shape other than rounded. What do you mean by rounded? That means the round is always convex outside, never concave outside. Any concavity outside, for example, this shadow is concavity. This cannot be a lymph node. This can be a lymph node. This can be a lymph node, concavity outside. Suppose if you find a convexity outside, you may doubt whether it may or may not be lymph node. But if you see any other margin and then see a margin with convexity outside, then it is a lymph node. Did you understand? Did you understand? Please type U. You must identify convexity outside. No. They may cause displacement or compression of the airways based on the location. If they may or may not press. It's not the rule that lymph nodes should press. You understand? They are often asymmetric and irregular in margin. Margin is not perfect round. Perfect round means it can be a button artifact. Suppose you kept a coin, it can on the hilar area, you don't say it is a lymph node button. You understand? That type of nice margins lymph node don't give. Little bit of asymmetric and irregular margins you get, commonly seen in TB, lymphoma, or infection. Now, any disease will cause lymphadenopathy. Now, sir, why in TB there is lymphadenopathy? Will you all get me a coffee? Say yes, sir. If I tell you this trick today, most important point. TB versus non-TB. Now, what happens in TB? In TB, the progression of pneumonia is slow. Pneumonia progresses slowly in TB over weeks. It goes on evolving. Did you understand? By the time the pneumonia evolves, lymphadenopathy also evolves. Therefore, you see a pneumonia plus lymphadenopathy in a TB. Sir, does that mean streptococcus, staphylococcus pneumonia don't cause lymphadenopathy? They also cause lymphadenopathy. By the time the lymphadenopathy get recognized as a radiological sign, he will die from pneumonia. That means to say, there is a pneumonia. It cannot be left untreated or without progress or resolve till a lymph node enlarges in size. It should be a slowly progressive pneumonia for you to identify lymphadenopathy. Please type L if you like this. You should understand this concept over a period of time. Therefore, only in TB we look for lymph nodes. I would say, don't say TB. Any chronic pneumonia can be associated with lymphadenopathy. Acute and hyperacute pneumonias don't cause lymphadenopathy, or they cause lymphadenopathy, but you will not pick them up. There is a small reactive lymphadenitis, but that reactive lymphadenitis is not reflected radiologically large enough. If you think lymph node is large, that means to say it's more chronic. And I would say more chronic or more rapidly growing, which happens in malignancy. You understand? Either if it is slow growing but long standing, then it can increase in size, or rapid growing is malignancy. Now I'll come to a point of lymphoma versus TB for you. If you don't find a, if you don't find, if you have a doubt, you have to take biopsy or you have to take CT scan, because X-ray has a limitation here to differentiate between TB and non-TB. Very, very difficult. But you should not get confused about mediastinal adenopathy. You can make a diagnosis. I'll repeat for you. The lymphadenopathy should be in the location of lymph nodes. Number 1, paratracheal, carinal, hilar, etc. Second, they produce the effects: paratracheal denting, widening of the carina, compression of the airways, producing localized air trapping. I have shown you signs of air trapping. Collapse. I have showed you signs of collapse. Pneumonia, recurrent pneumonia. I have explained to you. You understand? Or deviation, pull, tug, etc. All these things can happen because of the location of the lymph node. They are called as secondary effects. Third, the description of the radio density should be matching that of a solid structure. That means it should match with that of the fluid nearly in density. Number 4, it will have a bit of irregular margin because artifacts have got perfect margins. Now, fifth, it will have a convex margin. The location will tell you it is a lymph node. If you take the history, you will know duration of the fever and the responsible etiology. Short duration, no lymphadenopathy can be explained. If you have a short duration fever and a big lymph node, it can be malignancy, rarely tuberculosis, unless history is incorrect. Or if you have an evolving disease, pre-existing lymphadenopathy and now a fever, you can get mixed. So my point is that there need not be a textbook reading and a perfection on this, but only thing is that you need to correlate this with the clinical history and make a diagnosis. Don't tell me Hilar lymphadenopathy is a graveyard. You can make an analysis. You continue to debate this in WhatsApp groups that you are having. You will make a diagnosis. Is mediastinal adenopathy a TB? I have answered for you. But you need a CT scan. Advantage of CT scan is that it can give you liquefactive necrosis, caseating necrosis that you see in TB. It can be seen on a CT scan. But even finding that is not enough, because you need to know whether it is MDR TB or not MDR TB. So therefore, you need an aspiration and a CBNAT to find out whether it is what it is. So radiologically, TB can be diagnosed by lymphadenopathy, miliary nodules, or by cavitation, or an airspace disease and effusion. But airspace disease and a pleural effusion are abnormal findings, but they are inconclusive findings, but common findings in TB. This is very, very important for all of you. 2-year-old female with new onset stridor. There is a unilateral asymmetry and look for foreign body. I'm coming to end of it. 2-month-old with cough in the ER. This is diaphragmatic hernia. And for cardiac cases, please don't do too much into X-rays. Please do 2D echo. It is simpler than repeating an X-ray. Don't repeat an X-ray. It is only for exams of undergraduates and postgraduates that we ask the question of egg, end on a shoe, and all that. Don't by heart them. It's of no use to you in life. Asymmetric. This 2-year-old child with systolic murmur was asked for 2D echo. This was the child. And when X-ray was repeated, the X-ray became all right. Problem was the echo was ordered based on expiratory film. See, look at this example I gave you, because often we don't diagnose cardiomegaly by looking at the X-ray. See, 1, 2, 3, 4, 4 anterior ribs are seen. This cardiomegaly is only because of expiration. Don't order an echocardiography. I'm just giving you some of the applications. Actually, this was the break. I don't know whether you need the break or will come to the end of it. Any of you wants to repeat or come in, please raise your hands in the chat box. I will allow you inside. I will just tell you last 4 slides of mine. X-ray are important because they are low cost, easily available. They are prone to errors because it is a low contrast resolution. CT is a high contrast resolution. X-rays is not a solution to all our problems. Can't say let X-ray solve the problem. No. Indications of the X-ray, these are wrong indications. I've done when it is there. When I know the diagnosis, I want to just confirm by X-ray. No, that is wrong. When we cannot examine, when we have not examined, let the X-ray examine is not correct because I showed you so much. You learned from past 3-4 hours. Don't do an X-ray because the parents ask. Don't do it as a routine. And don't do it to buy time. Don't do it to clear the OPD. These are wrong indications. You will be in trouble after doing X-ray in interpreting the X-rays. Order only if it is required. Always read in front of a view box and go distance and then see. Don't go close to the X-ray. It will not give you more findings. That is a distraction. Digital X-rays are better. And you can use newer techniques for interpretation. Like you can create this in AI. One image like this and overlap it on an X-ray and then see in your laptop or in your mobile. Very easy. Read in an appropriate setting. Know the normal chest and know the normal anatomy. And you need to know all these points. Read upper zone, then read mid zone, lower zone, and then go to retro upper areas and hidden areas. You will have a systematic approach. You can see lungs, Hilar, trachea, cardia, and then finish everything. Or you can go say trachea, cardia, cardiophrenic angle, diaphragms, upper zone, mid zone, lower zone, compare left with the right. Should have a systematic approach. These are the hidden areas. There is lung there, but we miss the lungs there. There is lung above the hilum. There is a lung behind the liver, which all of you have seen. Now in a pleural effusion, you understand. There is a lung behind the bubble of the diaphragm. We miss them. All these, even there is a lung above the rib, but we say there is a rib, but there is a rib and a lung when we miss them. So major of the areas we don't see. You need a radiological eye to see the X-rays, my dear friends. Eyes cannot see what mind doesn't know. Beware of interpretation pitfalls, and you need to make a clinical diagnosis, radiological diagnosis, correlate and make a final diagnosis. Often we end up say, I have this is my diagnosis, whether the X-ray correlates or not. Mix the two and make a conclusive diagnosis. Interpretation of chest X-rays can be of two types. Can have a normal child and a normal X-ray. That means the child is normal. Suppose it is a normal X-ray, a normal child, but X-ray is abnormal. Then it is because of thymus and artifacts. That means child is normal, X-ray is abnormal. That means it is thymus or artifacts or exposure film. All these PA, AP, whatever I have told you, rotation, understand. Child is normal, X-ray is abnormal. You understand? If the child is normal and X-ray is also normal, then it is not indicated and you have done. And it's because of day-to-day problem. Let's say child is abnormal. Even if X-ray is abnormal, that it is an abnormal finding. Please remember, if chest X-ray is normal, but child is abnormal, then it is very scary for me. That is because it is for a physiology or done in X-ray, which is not correct. Asthma, for example, chest X-ray is normal, but child is abnormal. And if chest X-ray is normal, and abnormal and child is abnormal, you are the correct pediatrician. You have done it for indication, disease and complications of diseases, which I told you is the most important slide. I'll go for live interaction. I want you people, please in the participant list raise your hands and I will allow you to be inside. You can discuss whatever you want to discuss. You can comment, and after this 10-15 minutes or 10 minutes or so, we'll close. Now, any of you please raise your hands in the, I'm not able to see. Okay, I will just see Dr. Sojula, Saluja. Okay, I'll type Saluja and allow you inside. I'll allow you to talk. Saluja, you are inside. Anybody raise the hands in the chat box, I'll allow you. But before I would finish, I want all of you to mark the attendance. Only then the certificate is given. Already 60 people have left. We will not get attendance for them or any certificates. They will not know what is what. 1 second, I'll just get that. Please, any one of you, please raise your hands. I will allow you. Allow you to come inside. I'll allow you to come inside, please. No, present, sir, won't do. But Dr. Sajula, you want to speak anything? You can unmute and speak. Anybody else? I've seen the hands being raised. 1 second, I'll allow all of you. I'll allow you to speak. Any of you can speak, comment, or you can present your X-rays and discuss. This forum is open for you now. Don't leave, because there will be some valuable things that happens at the end of the discussion. Lastly, somebody will say some important points. And if you can speak, unmute and speak, present, share, whatever
Sir,
you
how
want.
will you differentiate between a bronchopneumonia and an interstitial uh, disease if it is localized to one part of the lung?
Okay, now the answer is simple. First point is clinically. Now the issue is that all of you should remember that whenever you have a pneumonia, you will always have disproportionate hypoxia in an interstitial disease. Breathlessness will be more, distress will be more. You understand? Like in an influenza, adenoviral epidemic, you must have faced viral diseases or complicated bacterial disease. That is point number one. This is clinical. Next is you will have an ABG evidence of oxygen depth. Number two, you will have that SpO2, PaO2 ratios, etc. clinically making it as a PRDS. Now, if I come to radiologically, you will always see that the vascular pattern doesn't follow, or any that pattern doesn't follow Bombay to Goa from hilum to the periphery. They are broken lines. They may follow reticular, nodular, or lace-like pattern, mixed pattern, etc. There will be an air contrast. That is how you have to differentiate an interstitial from an alveolar shadow. Is that okay for you? I'm repeating it for you. But
Yes, sir.
I want all of you to stay in the group. Don't leave the group. Message to me on WhatsApp. I'll share you that attendance link. And also, that's my mobile number. I'll share with you. Please, will share the slides to only those who message to me, while I'll take the attendance at that time. And now I'll share my mobile number. You can ask the doubts also. I have no problem. Now I have messaged to you. Is that no, wrong number? 1 second. I'll come. Sorry, that's a wrong number. I'll delete. 1 second. I'll type properly. I'll share my number so that you can all message to me. I'll share you the slides, explanation, videos. Everything will be based on. I'll send on one-on-one basis. That's because they should not misuse the slides. Therefore, message to me individually. I'll share all the slides to you, all the reading material, everything. Now, shared my mobile number. Message to me on this number. Anybody else wants to speak anything, please? I'll share the slides only if I get the message to my WhatsApp number. I'll share my slide of my mobile number probably, so that all of you can take the screenshot of that and then send to me. This is my mobile number. Please send a message. Sir, send the slides. Send a PDF of this Felsen book. Everything I'll send you. Pulmonary edema is interstitial. Bronchopneumonia is alveolar. I'll share with you each and everything. There is absolutely no problem. Okay. If there is anybody who wants to discuss any of your X-rays, you are open. Otherwise, I'll close the session. Please type what you want me to do. Hyperinflation and air trapping are same. Hyperinflation is an effect of air trapping. Dr. Rajkumar. This number you please save so that you know all of you can message to me so that you will all know this and you can get to me on this WhatsApp. It's easy for me to share from this number. I will tell. Just wait for some time. My secretary, she will start sharing whatever you want. You want slides, you want presentation, you want video. If you have doubts also, you can message to me. I will reply to individually. But doubts, please ask in the group. Because then every other person I can't type. So they will answer. Is that okay? So if there is no comments from anyone wants to speak anything, you are allowed. Otherwise, I'll just viral and bacterial bronchopneumonia. And pneumonia is viral or bacterial is clinical diagnosis, not radiological diagnosis. So I'll close now. Thank you very much, and I'll stop recording.